Good morning. I think the air is going to be a little bit warmer today, so I hope y'all will leave early. I'm Connie Easterling, if you weren't here yesterday, and I'm the moderator for today's program. I do want to tell you we have a break at 10:30, and I forgot what else I wanted to tell you, but that's all right. We're going to introduce our first speaker. Dr. Coyle likes to get started right away, so we'll help her do that. She is professor of neurology and founding director of the Stony Brook MS Comprehensive Care Center at Renaissance School of Medicine at Stony Brook University in New York. She is currently interim chair of the Department of Neurology. She is a recognized expert in MS and CNS disorders, and if you've never heard her speak, you're in for a treat. So, okay. She's the only faculty that was with us from the very first fundamentals in 2004.
Now, can we enlarge this or not? No?
Yeah, I think you can.
Okay.
Oh, I don't know.
We should be able to.
Yeah, you should. Maybe that. Oh, if I mess that up, I'll get in trouble. Maybe if you hit it. Nope, wrong.
Okay. All right. Well, it's not key. All right. Well, these are my disclosures. Basically, I've been giving this talk for a long time, and I update it each year, and I have a lot of slides. In 35 minutes, I'm going to go over some very, very quickly. Anybody is welcome to take the slide set. We're going to be talking about PPMS, and we'll review the diagnosis, how to approach it therapeutically with management, and then consider pathogenetic mechanisms as well, divided into 5 parts: an introduction, focusing on diagnosis, clinical course, long-term management, and ending with new insights. So we have 4 clinical phenotypes currently. There may be more coming. Everybody knows that we're going to have the 2024 revised diagnostic criteria for MS. This is the least common clinical phenotype, 10 to 15%, and that may be decreasing, okay? PPMS, there are a couple of studies that suggest the frequency of PPMS is going down, so we'll see if that's confirmed or not. This is sort of a unique phenotype. It's the only one that shows an equal sex ratio, men and women, 1-to-1, older age onset, very unusual in the pediatric onset. In fact, there are some esteemed MS pediatric neurology experts who say they've never seen a PPMS pediatric case, that if you probe them significantly enough, you'll find they don't have MS. I think that's a simple question that the pediatric MS community should answer. Is that really accurate or not? We are seeing an older age at onset of MS, and your proportion of PPMS goes up a little bit higher the older you are. So there are a couple of dynamic things at play in the demographics. Can you have PPMS and get a relapse? Of course. Our current thinking is there's a relapsing pathology, there's a progressive neurodegenerative pathology, and both are present in most MS individuals from a very early time point. So of course a PPMS could have a clinical attack, about 1.5% do each year. So PPMS is really the neurodegenerative, smoldering inflammation phase of MS, injury to synapses, axons, neurons, underlying progressive MS. And there's an age link. So even though the neurodegenerative, smoldering, inflammatory component is probably present silently very early, at midlife it can cross over, and you can see the clinical presentation of gradual deterioration, age 45 to 55. And the concept currently is that you've lost sufficient CNS reserve, you've had sufficient neurodegenerative, smoldering, inflammation-mediated damage to now see the clinical counterpart of gradual progression. We don't know if that's true, but that's the current thinking. That's the current thinking. And right now we have 2 phenotypes for progressive MS, PPMS and SPMS, and the feeling is they're an identical process. That has implications, important implications. It means if you have a study and you have a treatment that works for SPMS, there should be benefit for PPMS, and vice versa. And there are trials, progressive trials, where they're entering both SPMS and PPMS. So the diagnosis, you have to have gradual deterioration that is independent of relapses, so it doesn't occur suddenly. And you can actually be stable for prolonged periods of time, you can even see improvement, but otherwise it's really kind of slowly downhill. We recognize two ways to worsen, to develop disability, neurologic disability in MS. Raw, relapse-associated worsening with incomplete recovery from clinical attacks, a stepwise deterioration, and PIRA, progression independent of relapse activity. And that seems to be the most common way that an MS patient deteriorates unless they're in the pediatric onset age group where raw dominates. Now, if somebody's going to become progressive, they typically do before age 75, 99%. So if you get to about 70, above 70, and you're relapsing and you have not converted to progressive MS, then probably you're not going to. So PPMS, SPMS, we have a formal definition for PPMS. We don't have that for SPMS. You'll hear people talk about active versus not active and progressing versus not progressing as disease activity measures. Just a reminder, active is a clinical attack or a macroscopic lesion in the past year. Let's say you have to put a time frame. So people will talk about active or not active progressive MS. Just be aware of that. And this is the definition from the 2017 revised criteria. Everybody needs to know this if you take care of MS individuals. You should be able to quote this: a year of gradual deterioration, retrospective or prospective, and then 2 of 3 other criteria. And you can include CSF-specific oligoclonal bands there, or 2 spinal cord lesions, or 1 lesion in the brain. And of course, that has to be at least 3 millimeters or larger. And if it's periventricular or juxtacortical, you better make sure you're right, because experts make errors in that. So you want a very, very legitimate, excellent read. The 2017 criteria talked about progressive solitary sclerosis, which is a single lesion, typically in the cervical cord, and a slowly worsening course that they felt was a form fruste of primary progressive MS. I doubt very much that they'll mention that in the new criteria. Now, yes, thank you. So you have kind of a slightly different differential diagnosis for primary progressive MS versus relapsing MS. You really want to image the spinal cord extremely carefully. There are some genetic leukodystrophies. You don't want symmetric, significant white matter disease with the typical PPMS, and you can actually send genetic screens for that. And then there are metabolic, inflammatory, infectious processes. So there's a special differential diagnosis for primary progressive MS. And I would argue, because this is such an atypical clinical phenotype, you really need to work them up well. I think spinal fluid has to be included in everybody that's being worked up for PPMS. You should really include CSF evaluation. So this is kind of a typical workup. Now, you don't need to do a laboratory workup. You could make a clinical diagnosis of MS in certain cases, okay? But it would be foolish not to work the patient up. You can get important prognostic indicators, et cetera. So judicious selection of blood. You wouldn't typically test HTLV1 antibodies in a relapsing presentation, but in a primary progressive, probably yes, and perhaps very long-chain fatty acids and vitamin E. You want to do CSF probably after the 2024 diagnostic criteria come out. Maybe kappa-free light chain index is going to be added to the spinal fluid data. I mean, those are all the hints that we're hearing from the meeting here. And excellent neuroimaging. You make sure you do the thoracic cord down to the conus, along with the cervical, along with the brain, with and without contrast, at the time of diagnosis. Everybody deserves that. You want to know if there are silent spinal cord lesions baseline in your individual. So you have to image them and make sure it's good, because there are crappy imaging facilities out there that do terrible jobs, and they really should be following the protocols, and we need to present the protocols and really push that tremendously. Now, there's no pathognomonic MRI picture for PPMS because we're defining it strictly clinically, but there is a prototypic. There tend typically There are always exceptions, not to be a lot of macroscopic lesions, not to have a lot of T2, T1, or contrast lesions at all, but to really show more spinal cord pathology, which can often be kind of diffuse and mild changes within the spinal cord. And you see brain atrophy, particularly in gray matter. And you can see kind of some of these chronic active lesions. Now, they can be seen in RIS and CIS and relapsing MS, but they're particularly associated with progressive and not active progressive MS. This is the chronic active lesion with a demyelinated inactive core. It's not enhancing, it's chronic, but it's slowly getting bigger, and you have an active rim, microglia, some macrophages, and sometimes they've phagocytized iron, and you can pick them up as a slowly expanding lesion cell or pearl, phase rim, paramagnetic rim lesion. And they have a lot of microscopic damage. The prototypic PPMS patient looks pretty good macroscopically, but they have a lot of microscopic damage if you probe with these sorts of techniques, a lot of microscopic damage. That's your prototypic PPMS patient, microscopic injury from the neurodegenerative smoldering inflammation course. So the clinical course, most commonly a progressive spinal cord picture, spastic paraparesis, 83%. So that's how your PPMS patient will present. That's when you should have a suspicion and have that in the differential diagnosis. Second most common, 8%, progressive cerebellar syndrome. So you want to think about that. That's legitimate to put MS at the top of the list, and please rule out primary progressive MS. Then we go down to a progressive hemiplegia, just 6%, and then very rare is brainstem progression, cognitive progression, visual progression. It can happen, but it's 1%. So you really need to work up that patient carefully if you're going to call them PPMS based on that unusual clinical picture. And we know that progressive MS doesn't have a good prognosis. There's going to be disability. Now, it turns out when you look at the rate of progression, it varies, and you can actually see subset groups in PPMS. This is from a big MS-based registry where they had people that had mild progression, moderate progression, and severe progression, and you could define it in 1 year. The degree of progression in 1 year was pretty good at saying whether you were in a mild, moderate, or severe progression group. The probability of reaching an EDSS of 6 at 10 years was 0 in the mild group, 46% in the moderate group, and 82% in the severe group. So by tracking for even 1 year, that really helped. I have here a small Israeli study. It had 304 PPMS patients. They actually found 6 distinct trajectories, but I'm mentioning it because they had at one end of the spectrum, a very slow progression spectrum, 4.7%, where even after 20 years of PPMS, they had not reached an EDSS of 3. I think that's interesting to note and to quote to our patients because I think it gives some hope. So there was a small minority of PPMS that really very, very gradually worsened, and we're doing pretty good 20 years later. I think that's remarkable. We haven't paid sufficient attention because it's harder. Cervical cord volume loss or atrophy is not just mimicking the brain. It probably has very significant implications for progression, and it's something that we would want to get a better handle on, and probably an MRI imaging feature that we will someday track routinely, I think. We're not there yet. Icometrics is doing, brain, not so much the cervical cord, but this is something for the future that we're going to need to pay attention to. And this was just an analysis from Magnums across the board, and what they found was long-term disability progression really was looking at gray matter volume loss, in particular thalamic, but in the primary progressive cohort, putamenal, in this particular study showed the fastest volume loss. But following volume loss, which we are starting to do, the question is, can we bring it down to the individual level? I think ultimately we will. Ultimately we will. But we can certainly start to collect that data in a meaningful manner. This is a fun little term, brain predicted age difference. This uses artificial intelligence and machine learning to age the brain. So you can do that. So you get a chronological age, and then you actually subtract the true age of the patient. So if you have a positive result then, your brain is older than your age. And of course, with damage of MS, that can occur. So in a study of 1,200 MS and CIS individuals and 150 healthy controls, the mean brain pad, so the MRI age minus the chronological age, the actual age, was positive 6.7 years in CIS, 11.2 years in primary progressive MS, 11.9 years in relapsing MS, and 13.3 years in secondary progressive MS. That's terrible. The MS individuals had an older brain than their chronological age. I think this is looking at the assault on CNS reserve. The suggestion was that greater brain pad difference at baseline or developing greater differences on an annual basis was a very good marker for the person developing further disability progression. And that's something that we may follow in the future using AI machine learning. I've shown this slide every single year, and it's an old study from Canada where people were doing EDSS annually or biannually. What they found was there was a small proportion of PPMS patients that showed confirmed improvement for a period of time. It was only 8.4%. But I think this is a nice thing to talk about, along with that Israeli study that I mentioned, where you had almost 5% of PPMS that really didn't develop, a very slow development of disability progression over years. So there can be outliers and unusual circumstances, and I think we want to give hope to our patients. We always want to give hope to our patients. RIS, everybody knows radiologically isolated syndrome. In the global RIS database, about 12% subsequently developed PPMS at 5 years and at 10 years. For 5-year development of PPMS, being male, older, and having spinal cord lesions were markers of that. They disappeared at 10 years. You no longer saw markers for that, but it indicates that RIS can pick up silent PPMS, presumably. Silent PPMS, because about 12% of the RIS patients developed PPMS. So that's kind of interesting, an interesting study group there. What about prodromal MS? Is there a different prodrome for PPMS versus relapsing MS? We know we're talking about the prodrome now. And this is a hint that there may be. This was a study that suggested the prodrome might be different in those destined to present with PPMS versus relapsing CIS MS. And then a small Lithuanian study, it only had 166 patients, but they noted a difference in the prodrome in PPMS versus CIS relapsing MS. So that's further study that needs to be done. Cognitive impairment, this is a meta-analysis and systemic review of 47 studies, and it turned out in 37 of the 47, PPMS had greater cognitive loss. Now you might say, well, why could that be? Because you don't have the macroscopic lesions, you have the microscopic damage. You have excessive microscopic damage, so it really shouldn't be surprising. So it turns out that PPMS can turn out to have a lot of cognitive issues. So just to be aware of, et cetera, and to keep track of, et cetera. People are talking about biomarkers a lot at this meeting, and I honestly think biomarkers, if you can possibly use blood, either plasma or serum, that's going to be more meaningful than spinal fluid. We tap everybody, and I think if you had a great biomarker that was present in the CSF, and you could make the argument that this gives us extremely important data, I think that would be fine. But all things being equal, I think you'd always prefer a blood biomarker than a CSF. This was a very recent study that looked at blood and CSF from the OBO study, and they did 25 different CSF markers. And in a nutshell, what it found was GFAP, gliofibrillary acidic protein, seemed to be more meaningful for progressive forms of MS rather than neurofilament light protein. Didn't mean that you wouldn't want both, want data from both, but neurofilament light is disappointing for progressive MS as an axon neuron injury marker. It's disappointing. It seems to be tied particularly to progressive forms of MS and developing progression. Now, you want to know what neurofilament light is, because if you're on a high-efficacy agent like the B-cell lytic agents, the anti-CD20s, and you've basically knocked out your photoinflammatory relapsing component, if you see an elevation in neurofilament light, that may be predicting transition to progressive disease, like a failure of controlling the neurodegenerative smoldering inflammation arm. The other thing that came up from this very recently published study was that maybe we should be relooking at neurofilament-heavy protein, not just NFL, not just the neurofilament light, but the neurofilament-heavy protein, which we stopped looking at because we had a great assay for neurofilament light. But maybe we need to go back because there were some correlations with neurofilament-heavy chain that were not seen with neurofilament light chain. And these are just other biomarkers. Again, the interpretation is that they're saying, focus on GFAP, let's develop GFAP along with neurofilament light. Now, be aware that neurofilament light has the most studies and is the closest to actually on the cusp of being used, and you're beginning to see people start to use it, and I think its time has come a little bit, but we do want to make sure GFAP gets developed as well. Long-term management. You know, when you think about approaching PPMS, I think it's important to give hope, and you want to explain that the course is not inexorable, and I pointed out some beneficial things. You really want to, from the get-go, emphasize the importance of healthy lifestyle choices, following a wellness program, not smoking, getting good sleep, eating healthy, exercising, try to control body weight, mental stimulation, trying to have a positive attitude, and treating comorbid conditions. This is kind of a so-called holistic approach, but honestly, one of the issues with MS is that they're not aging well. They're aging poorly, and they're losing CNS reserve. So you're born with a certain degree of CNS reserve, but you also have lifestyle choices and things that happen to you in comorbid conditions that influence that. So you have to preach to people from the get-go, because we don't have a lot of therapeutic options for progressive MS at the current time. They are limited, and the patient is being sabotaged if they're not really following a healthy lifestyle as much as possible. We want to optimize symptomatic treatment as well. We have one approved PPMS drug. We have a drug that was used in a phase 3 trial of secondary progressive MS as well, but we have a lot of studies ongoing. And this is just an outline. You have to be prepared to talk about what is a wellness program if people don't know. The AAN treatment guidelines need to be modernized, but we only have the one formally approved treatment for PPMS because it's the only positive phase 3 trial. And they say offer ocrelizumab to PPMS when they're likely to benefit unless the risk outweighs the benefit. Evaluate reluctance or readiness to start a treatment. Counsel on realistic expectations, which I think is very important. You're not going to stop progression. This drug doesn't stop progression. At the best, you're going to slow it. Counsel about comorbidities, adverse health behaviors, potential drug interactions, and the PML risk. This is using artificial intelligence, machine learning, to predict therapeutic response from 3 trials of primary progressive MS. And you can rely on AI to pick out the treatment responders if you feed in the data. This is one of the waves of the future. We are likely going to be doing this in the future. It's interesting that ocrelizumab with the same trial got a different approval in Europe from the US. So in the US, it was adults with PPMS. In Europe, it was much more limited to that. So it's interesting. Look at the exact same data, the exact same trial, but we're not giving a uniform assessment or okay. It's just kind of weird to me. And this is the Oratorio study, and understand this anti-CD20 monoclonal doesn't penetrate the CNS. It's 0.1%. So it's acting on the systemic immune system to affect progression in PPMS. And you see the separation at 6 months there. So could we do much better with a CNS penetrating agent? That's the issue on the table right now, and we may, get some answers in the next couple of months. One of the issues that came up with ocrelizumab use in relapsing and PPMS, is it properly dosed if you have a significant BMI? If you're in the top quartile of weight, is it properly dosed? And they did a post hoc analysis that suggested it might not be. So they are testing higher dose. They're testing 1,200 milligrams of ocrelizumab every 6 months and 1,800 milligrams of ocrelizumab every 6 months. And those trials are ongoing, and we'll see if they wind up showing that 600 milligrams IV is not the right dose if you are a certain BMI or a certain weight. So we'll see what happens. Now, this is interesting because at this point in time, we're trying to pull back from giving anti-CD20, saying maybe we've been giving too many. But just be aware, they have data that has raised concerns that they may not be the right dose, and so they are testing that. Another thing, sub-Q ocrelizumab. So we heard about that at this meeting. So ocrelizumab has been IV, and that's why most of the people who chose it because it was a quick IV twice a year. But now they have sub-Q. It's like 23 cc's. It's not the same dose. They had to go to 920. Just personally, I can't see this being a winner. If you wanted sub-Q, why wouldn't you go to ofatumumab that has the little volume and studied it and looked at it? It makes no sense to me, okay? But we'll see. I could be wrong. I could be wrong. PPMS in the pandemic, we know that the anti-CD20s were kind of found most commonly, not in every series, to increase risk for COVID or more severe COVID. So that's just something to be aware of. We know it interferes with the antibody response to vaccines. So that's something to think about if we're using it in our PPMS patients. But it does seem, I don't want to speak too loud, like COVID is not what it used to be. Maybe it's herd immunity that we've gotten. Maybe it's milder strains. Let's hope it absolutely stays that way. But it doesn't seem to be as disruptive or bad. And we do have antiviral treatments that people can go on, and people continue to work on getting better control. Treatments. There's this little itty-bitty study of hydroxychloroquine from Canada that suggested a significantly less deterioration in PPMS versus the control group. This is an anti-glial strategy. So we're beginning to see anti-glial strategies to treat MS. What are some potential therapies? I want to mention masitinib. That's an oral tyrosine kinase inhibitor that has an ongoing trial entering PPMS and secondary progressive MS. Ibutylast, an oral phosphodiesterase agent, that had a positive phase 2 trial in slowing brain volume loss, at least in PPMS, didn't do it in SPMS in their analysis. But nobody's picked it up for a phase 3 trial. Nobody's picked it up. It's an oral, you take it twice a day. BTK inhibitors, excitement. We're going to get an answer. We're going to get some answers, yes or no. We just heard this morning Jeff talking about allogeneic EBV cytotoxic CD8 T cells, autologous or allogeneic. That doesn't make sense to me. You really think the immune response against EBV is driving the current MS damage? I don't buy that. I don't buy it. And they talked about a negative study. Depot-GA, given once a month, like every 28 to 30 days, and then CNS repair strategies, human umbilical cord blood cells. Metformin is something that's being studied in progressive MS. We heard about anti-CAR T-cell therapy this morning from Jeff, and acetylcysteine. So let me mention the BTK inhibitors. Great excitement. They target B cells. They are CNS penetrant, the ones that went to phase 3 trials. Supposedly they all are. You know, you have very good data with at least 2. And they target microglia then. So they target B cells and microglia. They're not cytotoxic. They stop them from being activated, okay? So CNS penetrant, so they can act on the systemic immune system. They can act on the intra-CNS immune system. There are 2 phase 3 trials in primary progressive MS, one with fenebrutinib versus ocrelizumab. So no placebo. The approved drug, ocrelizumab, you get randomized to, or oral fenebrutinib. And they are completely recruited, 946 patients. The second, tolebrutinib, given once a day, 60 milligrams with a meal. Their primary progressive trial is against placebo, but we will have some answers. They are fully recruited as of now. I think it's about 700 patients. So we have 2 phase 3 trials with 2 different oral BTK inhibitors in primary progressive MS. In addition, tolebrutinib has a phase 3 trial in non-relapsing secondary progressive MS. And some of these are likely to read out by the end of the year. So, gosh, if this is positive, excitement based on penetrating. If they're negative, what a downer, what a disappointment. So it's all going to ride on what is the primary outcome of these progressive trials, but it's kind of exciting. EBV, I mean, we heard a little bit of it talk. So the story is that if you have adult onset MS, you are EBV seropositive before that. There's never been a documented case. So if anybody has a documented case, please step up. I'd like to see the pediatric MS cohort try to answer that in pediatric MS. They are looking at cytotoxic CD8 T cells in progressive MS in very small trials. I don't get it. I don't think that's going to work. We heard about one negative study this morning. It doesn't quite make sense to me. GA Depot had a positive relapsing trial. They have not been approved in the United States. They have a teeny tiny primary progressive study. So they're looking at 30 patients. It's up to 148 weeks. 20 are getting 40 milligrams depot glutathione acetate once a month, and then they're going to have 10 that get 25 milligrams. That's not going to be enough to judge efficacy in primary progressive MS, but we'll see if we wind up getting that depot GA for relapsing MS, and then do they decide to commit further. CNS repair strategies, you can talk about that for improving recovery from a relapse. You can talk about trying to boost CNS reserve, and then you can talk about CNS repair that's not just remyelinization, but axon preservation, targeting toxic glia, blocking inhibitory repair factors, improving the energy supply of the CNS, replacing damaged or dead cells, and then the brain-computer interface and exoskeleton approaches. That's all CNS repair. So don't just talk about remyelinization. This is all CNS repair. You can implant a chip, and you can have somebody that's paralyzed move their limb through thought. That's pretty amazing. That's pretty amazing. So there have been small stem cell-based studies in progressive MS. This was a human fetal study that had a few things that looked a little bit positive. Mesenchymal stem cells, you can get that from multiple sources. That's more popular. How do you give that? You know, we don't know the best source of stem cells to give. We don't know the right amount to give. We don't know the best delivery system. Should it be intrathecal? In that study, it was intrathecal worked better than IV. How many times do we need to give it? There's a lot of fundamental unknowns that need to be worked out. We don't even know the best type of stem cell to give, okay? So that's like a problem. People get very excited about this. We heard about the autologous bone marrow from Jeff, you know, this morning that looks promising, but not so much for progressive MS. Really more relapsing MS early in the course, still ambulatory, et cetera. Metformin, interesting studies for metformin, which is an antioxidant. It should reduce inflammation. It should enhance myelination of oligodendrocytes, and so that's being studied in progressive MS. Finally, new insights. Our current thinking is we have focal inflammation underlying relapsing MS and neurodegeneration, smoldering inflammation underlying progressive MS, and all of us have both. The pathogenic mechanisms in progressive neurodegenerative smoldering MS, toxic glia, cortical demyelinization, diffuse neurodegenerative injury, injury to mitochondria, lessen fuel, ion channel changes, loss of the ability to repair, remyelinization, glutamate excitotoxicity. Why do we care about these? Because we need better therapeutics. We need to understand what's the target of damage for progressive MS and get better therapeutics for that, and understanding what causes damage can help. We've had so much talk on chronic active lesions, which are particularly seen in progressive MS, but across the board. You have slowly expanding lesions and pearls. It seems like pearls may be a diagnostic biomarker that maybe are going to be addressed by the new diagnostic criteria. Greater than 4 pearls predicts PIRA. In a recent study, predicted PIRA two years later. But you really need to have an easy way to identify them on the MRI scan. We need better standardization. And there's this weird age relationship. We need to understand it, where there seems to be accelerated aging in progressive MS. Is this related to the microbiome? Does the microbiome get old and it doesn't work as well? Should we try to rejuvenate the microbiome? Could there be a neural network dysfunction that's playing a role in neurodegeneration? People are talking about that. Senescent cells, we know there are increased senescent cells in primary progressive MS. Could that be a target, a therapeutic target? That's a possibility in the future. It hasn't happened yet, but people are talking about that. And we're getting new insights from studies. So this is just one example where they took autopsies. They took 6 progressive MS, 3 controls. They did very careful analyses of active lesions, chronic active lesions, remyelinating, and then control white matter. And they have findings from the autopsy studies of progressive MS that are showing some unique glial patterns, for example, and giving us insight into what might be contributing to progressive MS. So these are kind of exciting landmark studies. PIRA, no uniform definition for progression independent of relapse activity. We need a uniform definition. We need to understand it well. PIRA, if it lasts long enough, if it's confirmed, if it's sustained, is progression, the appearance of clinical progression, and might mark a relapsing patient becoming secondary progressive. And primary progressive, that's not an issue because they are going to worsen predominantly by PIRA. We need better ways to tackle that. So our challenges are, can we improve the diagnosis of PPMS, particularly early, identify the critical mechanisms of damage to drive our therapeutics, improve our treatment strategies, develop CNS repair, and determine whether all progressive MS individuals should truly be pooled. And my final slide, progressive MS is distinct from relapsing MS. I know they're trying to say it's homogeneous. By that they mean virtually everybody has both pathologies. So it's not going to develop later. You have that pathology early of progressive MS along with relapsing MS, but maybe it's mild, maybe it's kept in check, but still they are distinct. Progressive MS represents the neurodegenerative, smoldering, inflammatory component. You have to have a holistic approach. That's extraordinarily important to talk to the patient early. We have one direct treatment. We hope we have more coming. We're getting promising future CNS repair strategies that will be very pertinent to PPMS, and certainly indirect strategies to boost CNS reserve. And will CNS penetration be a key to better treatment? That's our issue. Thank you. If anybody has a quick question, I'll be happy to answer before we go to the next speaker. No? So I skipped over a slide where they did 2 distinct molecular techniques, and in one, DNA aptamers in the spinal fluid, primary progressive and SPMS were indistinguishable. And then in another molecular study, they did kind of anti-inflammatory transposition studies, and they were different, okay? So the current thinking is that that's the same neurodegenerative smoldering inflammation component, but the SPMS would have a much more prominent relapsing focal inflammatory component. There are ongoing studies where they're pooling PPMS and SPMS. They have not decided to pull them apart. Thank you.
Thank you, Dr. Coyle. So nice to see you. Okay, our next speaker is David Lee, Dr. Lee. He is Professor Emeritus of Radiology and Associate Member in Neurology at the University of British Columbia. He is Emeritus Director of the UBC MS MRI Research Group and Associate Director, NARCOMS. How many of you in here don't know what NARCOMS is? Okay, we'll make sure you know what that is. That is the North American Registry for Care and Research in MS, and they put a journal out every quarter. So they'd be happy to send you a copy if you request it. He was formerly head of radiology at the UBC Hospital and interim head, Department of Neurology at the University of British Columbia. His primary research interest is the application of MR techniques in the study and care of patients with multiple sclerosis. Dr. Lee, you want to go? Your slides up? Good, good.
Thanks, Connie. I just want to make one point clear. How many of you know about NARCOMS, as she asked, and how many of you know about NARCRIMS? Those are two distinct entities, just like what we were talking about. Are they distinct or are they the same? So there is NARCOMS and there's NARCRIMS. So I'll leave it at that so that you can find out more about it. But thank you very much for asking me to be able to present on my favorite topic about MRI. So I'm going to be talking about MRI mimics in the diagnosis of multiple sclerosis. Okay, let's see if this will work. These are my disclosures and declarations. But most importantly, my disclosures are that I am part of an incredible team at the University of British Columbia, and there are lots of people there that I cannot mention, and if I did, I would finish my talk right then and there. And more importantly, I'm very thankful to a lot of volunteers and patients who have helped us with what we're doing to help us make changes to what we do in order to be able to benefit them, but also help us in terms of what we're able to do. I've been asked to really talk about MRI mimics, and what I'm going to do today is start off by showing you some of the typical MRI features. I know some of this was presented yesterday when you were going through it, but I wanted to highlight some of the MRI green flags and also some of the red flags in terms of what may be helpful as well as confirming, but also helpful in alerting you that it may not be MS. And then finally, I want to help you understand what are the pitfalls in the use of MRI in the diagnosis, and even more importantly at times, the misdiagnosis of MS. In other words, calling someone MS when they don't necessarily have MS. So let's start. You know, this whole thing about MRI and multiple sclerosis started in 1981. And I know many in this room probably were not born, or maybe were thoughts in their parents' minds, but it seems like a whole generation ago, or maybe 2 generations ago. And it started with the group at Hammersmith Hospital in London, where they showed pictures of CT scan on the left there, and then the MRI on the right, which showed many, many more black spots, which were indicating the MS lesion. And when those of us that were working at that time saw it, and particularly my mentor, Dr. Donald Patey, recognized that this was really a chance for us to be able to see MRI lesions as the pathologist was able to see them. And very quickly, this became recognized as being a tool that can be helpful in looking after patients with multiple sclerosis. You will have heard about how MRI is able to demonstrate lesions disseminated in space, and this is where MRI shows brain lesions scattered in different parts And you see here a FLAIR and a T2 scan showing different white spots which indicate MRI lesions. And this has been used by the International Panel for the Diagnosis of MS as the basis for using MRI to give you that evidence of dissemination in space. So the key areas that we look for MRI is the spinal cord, the juxtacortical or cortical, in other words, lesions that are sitting either in the cortex or next to the cortex, but still touching the cortex, paraventricular, around the ventricles, but they have to touch the ventricles, and then infratentorial, in other words, below the tentorium in the area of the brainstem and the cerebellum. The MRI criteria involves having to have at least 2 out of those 4 areas involved. And then the other thing that MRI can help in terms of the diagnosis of MS is showing evidence of dissemination in time, because those are the 2 critical aspects of diagnosis, space and time. And so what MRI can do in terms of showing dissemination in time is really showing the simultaneous presence of GAD-enhancing lesions, which show activity that time because it's showing the breakdown in blood-brain barrier with the gadolinium enhancing, as well as other lesions which are not enhancing, showing you that there are these lesions that are separated in time. Or if you had 2 scans, showing evidence that there is a new lesion that has appeared on a follow-up scan. So this is where MR has been really a very useful tool in terms of helping with the diagnosis of MS. Not that you necessarily need it, because if you have clinical evidence of dissemination in space and dissemination in time, you do not need MRI to provide that additional explanation. Now, here's an example of 2 scans done 6 months apart, and if I remove that arrow, you can see that there are changes. And for those of you who are awake now, it's past getting close to 10 o'clock. There are the 2 new lesions that have appeared. And here are the enhancing lesions that go with it, telling you that those 2 areas are fairly acute in terms of their activity. So in many ways, MS, as we know it, is something that is evident clinically, but underneath all that, there's a lot of activity. MRI showing you active lesions. MRI is also showing you progressive changes in terms of volume changes, showing you some of the things that Dr. Kroll mentioned in terms of paramagnetic rim lesions, and also chronically active lesions, which are silent, but nevertheless making changes to the brain. Here are some dark lesions that are associated with acute chronic black holes that are important, because if you look at the 2 scans, the GAD-enhancing lesion is associated with a dark area, and that dark area represents edema during the acute phase. But after about 7 months, the gadolinium is no longer enhancing, but we're still left with a black hole, and this black hole indicates that that part of the brain has not healed, has not repaired, and these chronic T1 hypointense black holes are really evidence of changes that show more severe axonal loss. They're associated with people with worse disability and disease progression than can be shown with T2 burden of disease. Brain volume loss I mentioned, and it's amazing when you look at these. On the left is a healthy control with the lateral ventricles being evident there in the center. And if you look at that lateral ventricle, you can see that for a person who is 1.5 years with MS, that ventricle is larger. And as Dr. Kroll also mentioned, when we talk about predicted brain age versus chronological age, you can see that that person, ventricles are getting bigger because their brain volume is losing. And then here's on the extreme right side is a patient who's had MS for 13 years with EDSS of 6.5. However, this is not something that is sort of predictable in a sense for everybody. Yes, there are some markers that are now helping us to predict who might progress and have those changes more evidently. But let me show you several patients in terms of MRI changes over 8 years. If you look at this first patient, I would struggle to see that there is any change. They look very similar, and perhaps if we did quantitative measures and used machine learning, maybe there might be some subtle changes. Compare that with this next patient. There is more T2 white matter lesion around the ventricle. Now, obviously, this patient is developing more T2 lesion, and if you look at the ventricle, they are getting a bit bigger. Compare it with this patient, who has many more MS lesions in terms of those white spots, and the ventricles have gotten much bigger. And here's another person who seems to have had less white matter changes, but the ventricles have increased tremendously. So it's not the same for every patient. Everybody has a different course in a way, and this is what makes MS looking after patients difficult, because as Dr. Cole also mentioned, there are very different trajectories for different people. And so it's important that we recognize that the findings that we have are individual. Many of the studies that we've done are group studies. And so translating what we've learned from group studies to the individual is difficult, but requires a lot of work. So let me then direct you back to the International Panel on Diagnosis of MS. The key to the diagnosis of MS is that it should be primarily made on clinical grounds. Patient needs to be presenting with symptoms that are typical for MS, not atypical, but they should be typical so that the clinician is suspicious that this may be MS. And what they're looking for is that there is dissemination of CNS lesions in space and time. And as I said, this can be found from the clinical examination, but MRI is of tremendous help because it can provide that evidence of dissemination in time and space, which aids in the diagnosis. But the highlighted part of it is that there should be no better explanation. And this is something that we often forget, is that there should really be no better explanation for what is presenting in front of us. So let me show you some MRI green flags. The spinal cord is a very, very important part of it. And the reason that the spinal cord is important is because having lesions in the spinal cord in healthy, normal subjects, even in the older age group, is very, very unusual. And even with people with other diseases, it occurs not very frequently, in less than 10%, compared to people with MS, where it can be found in 50 to 90% of patients with definite MS. And even in their first presentation, it may occur in about 30 to 40%. So seeing lesions in the spinal cord is a green flag because it should alert you that this is more likely to be MS, particularly if you're suspicious for it. The changes on the spinal cord with MS is that they're discrete and focal. In other words, they're not long segments. You can see several of them on the slide there. And they tend to be more located in a wedge shape around the margins of the spinal cord. They do not involve more than 2 vertebral segments, and they tend to be much more common in the cervical area than they are in the thoracic area. Another area that's a green flag is being able to see lesions in the corpus callosum. And they're much more common in MS patients than they are in healthy controls or even people with other CNS diseases. And one type of lesion that we're hearing more and more of are the, you heard about central vein sign. Well, the basis for the central vein sign is the oval lesion that we typically see with MS. The lesions that project from the ventricle tend to be oval. They go away from the ventricle. Originally, they were called Dawson's fingers because they look like a finger stuck up from the ventricle. And these, again, are green flags. When you see them, they're much more common with MS than other white matter diseases, which I will show you a little bit later on. You see them in sagittal plane, sticking out like fingers. And as we now have learned, that vein that is associated with the central vein sign is passing in the middle of the oval lesion because the inflammation that we have occurs around that venule. And so this black dot, or the vein in the middle of the lesion, the central vein has become a very important biomarker, because what we see is that people with MS tend to have it much more commonly than other neurological diseases. The central vein, when people have looked at it in terms of multiple sclerosis compared to other diseases, can be seen in a much higher proportion. There have been various methods of trying to determine what is the best threshold. In this study, they used 35% or more than 3 lesions. In other studies, currently 40% is what people have been using. And people have also been looking at 3 lesions or 6 lesions in terms of trying to determine how likely it is to be MS. The other lesion that you've heard about are the paramagnetic rim lesions, or the phase rim lesions, or the peripheral rim lesions. They are a component of the so-called chronic active lesion, the smoldering lesion that is occurring. If you look at the top row of scans, you will see that there is a lesion there that does not have a rim, as opposed to when you look on the lower part, there is a black rim around the lesion. The arrows highlight them. What these chronic active lesions represent is, in the center, fully demyelination with axonal loss, and then around the rim, there's microglia, macrophage inflammation, and iron, which is the basis for why there is a black rim. Iron deposition in those areas allow us to see that black rim. Having the peripheral rim lesions or paramagnetic rim lesions, as has been mentioned, especially if you have more than 4 of them, is associated with much worse motor and cognitive disability and occurring at an earlier stage, and is also associated with people with smaller brain volumes, and particularly involving the basal ganglia. But one of the things that we've learned more recently is having paramagnetic rim lesion is also helpful in diagnosis. Here's a study where if you had 1 paramagnetic rim lesion, comparing MS versus non-MS patient, it gives you a specificity of indicating MS versus non-MS with a high specificity. It's not that sensitive in that it only occurs in 52% of patients. Having a central vein with the 40% rule is very, very helpful, as I indicated. 99% sensitivity with a specificity of 96%. And if you combine them, if you insist on having 2 of them, you have a very high specificity, very high likelihood that you're not going to have a false positive. But the sensitivity obviously goes down, mainly because the peripheral rim lesions are not that common. But having if you see a peripheral rim lesion, it should point out to you that this is a high chance of being MS. Here is a more recent study that was published, which combined central vein sign, paramagnetic rim lesion with cortical lesions. And here, if you look at these 3 things, you'll see again the specificity is very, very high. Being able to see these will help you indicate MS versus non-MS. And in fact, one of the things that people have done is, as I said, there are various ways of looking at the central vein, and this is part of the thing that we will have to work out very clearly, how to use the central vein sign. We know that the central vein is there, but how do you do it? Can you count every lesion to indicate that 40% of them are more? Well, that could be a bit tedious, and I don't think I would have the time to be able to do that if someone has a lot of lesions. However, people have looked at, well, if you can find 3 lesions with central vein, maybe that would be all that you need. Or maybe 6 lesions, maybe that's what you need. And you can see here that if you use the 40% rule, 97% sensitivity, 96% specificity, if you use only 3, you decrease the specificity a little bit. But you use 6, the sensitivity goes down because you're looking for more lesions, but you have better specificity. And again, combining these can be helpful. So these are all indications to us of green flags. Central vein, paramagnetic rim lesions, cortical lesions are very helpful in terms of diagnosis. So let's go the other way. What are red flags? What are things that we see on MR that should alert us that maybe this is not MS? Well, when you have something that's big and pushing and causing mass effect, you need to think that this may not be MS. Here are 3 people with changes there. Which do you think might be MS? Who says none of them? Who says one of them might be MS? How about 2 of them? 3 of them? Well, I guess you heard my message. Don't look for things that are pushing. In fact, there is one subject here who has MS. And this patient, if we look back, there wasn't much, although it was very large, it wasn't really pushing. And so this is a patient with a large, what we call a tumefactive MS. It's big, but the actual acute lesion is that small area with a little round enhancing ring. The others, one is an abscess, the other one is a glioblastoma, a tumor. So those are red flags. If you see a mass, be very, very careful and think more about it, and gadolinium can be helpful. Here's another patient with a lot of white matter disease. This patient, when you look at the enhancement, part of it is enhancing. And if I were to tell you that this was a patient who has had a 10-day prior history of lower abdominal pain with vomiting and urinary symptoms, presenting with fever, ataxia, and confusion, even though the white matter changes makes you wonder, that is not a typical history of MS. And in fact, if you do a follow-up on this patient, there is only a little bit of gadolinium, and then what we have here is a case of acute disseminated encephalomyelitis, much more extensive. And in fact, this patient, 1 month later, most of the lesions have in fact resolved. Here's another person, 22-year-old Chinese lady with optic neuritis and lower limb weakness. Certainly this person could have MS. They have some of the symptoms. However, when we look at this patient's brain, this is the brain MR, and here is the spinal cord of this patient. He's got a very, very long segment of spinal cord involvement. And so for those of you that are already familiar and don't really need to be here in the fundamental course, you know what this is. This is NMO, SD, or neuromyelitis optica. What about this one in terms of the MR findings? There is a cord change. It's occurring in the part of the cord that we call the conus, and it's occurring right in the center. And if you look there, this patient's optic nerve is enhancing quite extensively and involving quite a bit of it. And here's a very unusual and fairly large lesion in the cerebellar peduncle. This patient has MOG, anti-MOG, myelin oligodendrocyte glycoprotein antibody disease. And these are findings that are fairly typical. And you know, Brenda Banwell and the group there have put together a very nice article. And if you have time, make sure you look up that Lancet Neurology paper, because it helps us differentiate between MS, NMOSD, and MOG. And I'm just going to run through this very quickly. I won't allow time to really go through it, but highlight where MS is more typical. Typical changes on MR for the optic nerve in MS is it tends to be unilateral, involving only one side, whereas the other two tends to be bilateral. It tends to be more anterior for MS, whereas for NMO, it tends to be more posterior, and in fact, posterior frequently involving the chiasm. MOGAD can be anterior at the onset, but it also tends to be longitudinal over time, whereas MS tends to be short. When we look at the brain, when we look at the spinal cord, as I showed you, MS typically are multiple, and I must have a typo, it's multiple, I guess needs to be multiple more than once, focal lesions, whereas NMO tends to be long, extensive, but they can be multiple as well. MS tends to be posterior and only a portion of the cross-section, more typically on the lateral aspect, and very rarely does it occur in the conus, whereas with NMO, SD, it's also rare, but as I showed you in that example, MOGAD is where the conus is typically involved, and centrally involving the gray matter. And then in the brain, we've already seen how MS tends to be multifocal, whereas with NMO and MOGAD, they may in fact be normal at presentation. And if there are changes, they tend to be very different from what we see with MS. We talked about the green flags, oval lesion indicating the central vein, round, well-demarcated, slowly evolving lesions, whereas with NMO, they tend to occur in areas where the aquaporin 4 is rich. So typically around the cortical spinal tract, it can be found in the medulla, in the area postrema. And then MOGAD, if it does occur, tend to be more poorly defined and more fluffy, like that large lesion in the middle cerebellar peduncle. When we give gadolinium with MS, they tend to be oval or they can be ring-like, whereas with NMO and MOGAD, they're more unusual, more cloud-like with NMO. And then with MOGAD, you may get leptomeningeal enhancement to go along with it. And then in terms of resolution, it's very rare for MS lesions to all go away, particularly with new scanners that we have nowadays with 1 millimeter resolution. When we used to start looking at them in 5 millimeters, yes, a 3 millimeter you may no longer see if you follow up, but nowadays it's very rare for it to have complete resolution, very infrequent. Whereas with the others, there may be partial or complete resolution. And in terms of the opposite, in terms of improvement, silent accrual is, in fact, a hallmark of MS, dissemination in time, whereas with the others, it's infrequent to gain new lesions. And then having that leftover black hole is, again, a common occurrence with MS, very rare for MOGAD, and may be present for NMO. So I talked about MRI in terms of NMO, MS, and MOGAD, but there are other things when you look at the MRI, and I won't have time to go through many, many other red flags, but just simply mention it to you. If we see central venous sinus thrombosis, we need to be careful. If we see things that look like infarcts in the cortex, little spots in basal ganglia, lacunar infarcts, if we see areas of hemorrhage, those should be major red flags. Similarly, if we see calcifications on CT, unusual that we would get CT nowadays, but if it involves the anterior temporal and inferior frontal lobes, typical and predominant, again, we need to be careful. And similarly, if the gadolinium enhancement doesn't last only 1 or 2 months, but continues to be there when you do a follow-up, even in 2 months, you need to be careful. Continued enlargement, continued enhancement. If there's enhancement of all the lesions that are there, that's very unusual for MS because it tends to occur only in the ones that are active at that point. If you see meningeal enhancement, you need to be careful again. Meningeal enhancement can be seen with MS because we are seeing some of these leptomeningeal enhancement as a sign of sort of the compartmentalized B cell, but it's not very, very easy to see and not something that really hits you in the face. If you see large infiltrating brainstem lesion, should be aware of it. And then if there are predominance of cortical lesion, in other words, you don't see the periventricular, you don't see some of the deep white matter lesion, but predominantly cortical, you need to be very, very careful. And then there are these very specialized things. So red flags, green flags, and what about the holes along the way that causes you to fall? Well, that's pitfalls. And the biggest pitfall, as I mentioned, was misdiagnosis of MS. Misdiagnosis of MS is a problem, particularly as we do more and more MR. Whereas before, people are entirely dependent on looking at clinical evidence. When we started doing MR, we started seeing a lot of white matter changes. And very often, when we see MR changes of white matter, we start wondering about misdiagnosis. This was a study done by Andrew Solomon and 4 US academic centers. And they had, if you can believe it, 110 patients that were misdiagnosed with MS. 70% of those patients, they were presented to them, were already receiving disease-modifying therapy. And 33% of them had a misdiagnosis for over 10 years, which is kind of scary. The most common alternative diagnoses are things like migraine, fibromyalgia, non-specific other things, and even NMO. So why were they misdiagnosed? Number one, atypical symptoms. I started out by saying it has to be someone with typical symptoms that you need to be aware that this is suspicious for MS. If people have atypical symptoms, you need to be aware that this may not be MS. I don't have time to go through it, and I'm not the person who will tell you about symptoms. I only look at the films. But there are publications that you should refer to, and I will highlight one a little bit later on in terms of it. But atypical symptoms was the primary, 65% of them. Lack of corroborating objective evidence of lesion was 48%. Over-reliance of MRI findings, 60%. And here, I'm guilty because I'm involved in creating MRs. And the reason for that is because, as we said, MRI findings in the white matter are very, very common. You won't have time to read, and if you can read it fast, good for you. But this is the differential diagnosis of white matter abnormalities. On the very top is MS, ADEM, and NMO. But look at all the other ones, vascular, and all these vascular-related things. Look at infectious, dysmyelinating, toxic, other etiologies. Many things can cause white matter disease. However, you say, well, MS is fairly common, is it not? Let me show you the prevalence of diseases with white matter abnormalities. Yes, MS is relatively common, 240 in 100,000 patients worldwide. For me in Canada, we have our center in Saskatoon. In Saskatchewan, they have 300, which is pretty high. Particularly if you compare it with neurosarcoid, lupus, Lyme disease, or hereditary causes, yes, it's much more common that you'll see white matter abnormalities. But this pales in comparison with vascular disease. Vascular disease can range from 5,000 to 50,000 depending on your age. As you get older, you get more spots in your brain. And that is a major problem, particularly as people with MS present older now. Question is, are those MS lesions or are they vascular-related things? And so this is where we need to be very careful in terms of simply depending on white matter changes that we see. I don't really have time to go over all the details for it, and most of you here are not radiologists, so I will skip through these very quickly, but mention that the key to this, and I highlighted many of them for you earlier on, is that there are green flags that we need to pay special attention to. The spinal cord is one. The oval lesions are there, and there are typical places where these occur. And GAD enhancement is more common with MS and very rare in vascular. And then I want to really highlight this part, and that is another reason why there was misdiagnosis is wrongful application of the McDonald criteria. So here is a scan of a patient with MS. Which is the periventricular lesion and which is the juxtacortical lesion? There are lots of lesions there. Here are the green ones. That one is a juxtacortical and that one is a periventricular. But these red ones are not juxtacortical. They're close to the cortex. One is in the deep white matter, and the one lower down on the left is close to the ventricle, but it's really not touching the ventricle. A study was done where these were shown to, experienced neurologists, and there was something like 20% of people miscalled what was juxtacortical and what was periventricular. You have to be very strict in terms of that. So let me finish off. To be able to see changes, dissemination in time, we need to be able to have good MR scans, and Dr. Kroll also mentioned that. And I leave that to the end, and I always talk about it because that's my only thing that I do these days is to push that we should do standardized MR, because standardized MR are so critical, because if you don't have a good MR, you're not going to be able to see the small lesions, you're not going to be able to see changes over time. These two scans were done 2 years apart. Are those real lesions? Well, the two scans are very different. it's obvious to you, they're done with different parameters, but they're also done with different slice thicknesses, and they're also done with different orientation of the scans, and that makes it very difficult. So being able to do a standardized MRI where you can compare apples with apples are so critical. And here you see a tiny little red dot. I don't know if any of you can see that little red dot. Is it more obvious when there's gadolinium enhancement? You see the white dot there now? That is a new lesion, tiny, yet we can see it because the scans are very comparable. So the consortium CMSC has been very, very instrumental, and particularly Don Patey, who's my mentor, really started all of this, if you can believe it, in 2006 when we had our first meeting saying that we need to do standardized MRs to be able to help our patients with MS. And the most recent, and we've had multiple revisions, and the most recent was the 2021 international guidelines where a group from Europe, as well as us in CMSC and the NAMES cooperative group got together and came up with new consensus guidelines. These are going to be updated as the diagnostic criteria are also going to be updated. But it's important to know that these are important to be able to do the standardized protocol. And I would urge you to stop by the CMSC booth, ask for these cards, because these cards show you what is necessary to get a good MRI. It tells you the parameters to be used, the slice thickness, and for those of you who have an influence on the radiologist, if you're going to order a scan, maybe you send the card to them and ask whether they do it that way. If you're a patient, you might show up at the MR center and ask them, show them the card, do you do it this way? And see what their look is when they look at the card. Because I will tell you, when we did a survey in my province 4 years ago, just before the pandemic, only 20% of all of our MRI centers were using the standardized protocol. We've worked hard, and last year when we repeated the survey, it was up to 80%. So it's something that we need to work hard, each and every one of us, to be able to do that, because MR is an indispensable tool in terms of helping with the diagnosis, and we didn't really talk about, but in terms of follow-up. So thank you very much for your attention. Well, if you don't want to have coffee and I spoke over time, you can ask questions, or I'll be down here.
Anna Shaw. She is an assistant professor of neurology at the Rocky Mountain MS Center at the University of Colorado School of Medicine. She also serves as the associate director of outpatient neurology at the University of Colorado Hospital, director for outpatient safety and experience. She's director of the family planning and MS clinic at the University of Colorado, and board of trustee member for the National MS Society Colorado Wyoming chapter. Very good. Okay, so Dr. Shaw is going to talk about women and MS. Okay, thank you.
Thank you. Hi, everyone. Good morning. So in the next 40 minutes or so, I'm going to try and take us along the whole lifespan of a woman's life as it relates to MS. I'll try and go not too fast, but just fast enough. So if there's questions, I'd love to hear them at the end. Here's my disclosures. The only ones really relevant for this talk, and I'm going to move this back because I think I'm talking too loud, is the off-label use of rituximab in this talk, and then also some of my funding for research has come from Genentech Roche that I'll show later. So our objectives for this next 40 minutes is, one, to understand the role puberty plays in the development of MS. Two, to talk about what is the optimal family planning paradigm of a discussion that we have with our patients in clinic. Three, to get a really good understanding of what natural history of MS does during pregnancy and postpartum, and then really think about what we can do to mitigate some of those risks. And then four, kind of talk about where we put disease-modifying therapies alongside all of this. So as we start with puberty, we'll start with just a little physiologic lesson. So when we talk about puberty, physiologic puberty, a little bit different in males versus females, but most girls go through puberty between the ages of 8 to 12, and most boys between 9 to 14. And puberty is essentially where we see a sustained release of gonadotropin-releasing hormone, and really goes on over the course of several years. Now, there's a ton of things that impact puberty, and I listed just a couple causes here, but we think about nutrition, environment. There's definitely genetic factors that impact what age someone goes through puberty. Race and ethnicity, some races and ethnic backgrounds are more prone to having earlier or later puberty. And the metabolic factors. So this study, I think, is a really interesting study where they looked at, well, what genetic variants do we see in individuals, and can we use that to predict when someone would go through puberty? And one of the things that was interesting is then they went and correlated this to risk of MS. And so what they found was that for every year you go through puberty later, your odds ratio of developing MS is 8% less, giving us an indication that there's some sort of hormonal component that comes into play when we think about the effects of puberty and the development of MS. The other thing that's really interesting about this study is we found that risk being negated if you're older when you go through puberty, that risk really gets negated if you have childhood obesity. So when I'm talking to patients, I'm counseling patients, one of the questions I always get is my child going to develop MS? And we talk sometimes about this study about what can we do to decrease that risk, and really trying to prevent childhood obesity the best we can is a huge factor. There's also this really nice study that was published by the U.S. Network of Pediatric MS Centers, where they looked at just under 500 kiddos and said, when did your MS symptoms start? At what age? And what discrepancies do we see between males and females? And what they found was most individuals had onset of symptoms after the age of 12, but after the age of 8, which is where we said that's the earliest part where most girls start puberty, there was a huge discrepancy where there really became a female predominance at a 2-to-1 ratio in terms of incidence of MS. And that becomes important for us to think about because, as we know, we talk a lot about MS being a primarily female-driven disease. We'll switch gears just briefly to the menstrual cycle. So we know the menstrual cycle has impacts on neurologic conditions. Here are 2 different neurologic conditions, which we won't talk about, but catamenial epilepsy and menstrual-related migraines, where we know onset of seizures or migraines get worse around the time of right before the menstrual cycle. And there was a really small study published in the mid-2000s that looked at this in multiple sclerosis. Small number of patients, just looked at 3 patients, but really found that the onset of symptoms got worse when their body basal temperature got worse, which was right before menstruation. Now, the reason I bring this up is if you have patients where they're saying, oh, I noticed the cyclical nature to my symptoms. I might feel more fatigued. There's a couple days every month, and I don't know what it is. It's really important to ask them about menstruation, because I've often found that there is this menses-associated symptomatic worsening. What do you do about it? I found that oral contraceptives have sometimes helped in those patients. If they're really bad, like if it's fatigue, I might tell them you can use modafinil just during this period of time, but anticipating it sometimes makes it feel less psychologically hard for patients, so it's something to keep in mind. So we're going to shift gears to kind of think about family planning, and that's where we're going to spend the bulk of our time talking about is family planning, pregnancy, and then the postpartum period. So why is this important? A lot of this is probably fairly straightforward, but the majority of our patients are women. 85% are diagnosed in their childbearing years, so between 18 and 45. And a separate but unrelated stat is almost half of all pregnancies in the U.S. are unintended. So as neurologists, as advanced care providers, as nurses, social workers, physical therapists, everybody who has hands on an MS patient, it is important to think about this because we know we don't really love accidents or unintended pregnancies, right? Especially in the setting of using specific disease-modifying therapies. Dr. Houchins did this really nice study where it looked at what are the rates of pregnancy in the United States versus in our patients with MS. And similar to what we're seeing globally, the rates of pregnancies, as depicted by that green line, are going down globally, going down in the United States. But what's interesting is we're seeing this rate increase in our patients with MS. And I think there's likely several causes for that. One, we're diagnosing people younger with more mild disease. I think we as a medical community feel a lot more comfortable with the data we have around pregnancy and family planning, so perhaps we're able to counsel better. But I think something that's important to think about is about 1/3 of all of our patients will have a child after diagnosis. So it becomes really important for all of us as part of patients' care teams to become familiar with what we're doing or how to deal with this optimally. We also know there's higher rates of comorbidities in patients living with MS compared to their peers. Increased comorbidities, particularly during pregnancy, things like high blood pressure, high cholesterol, really increase the risk of poor pregnancy outcomes. So the reason this becomes important is so we can communicate with patients' primary care doctors. We can communicate with their mental health team, whether it's psychology or psychiatry, and really say, can we set this patient up for ideal circumstances during pregnancy and in the postpartum period? Really quickly, there's been a few patient surveys looking at their experiences around family planning. 2 points I would illustrate is from that 2019 survey. 16% of people said they were discouraged to have a family by their medical professionals, which breaks my heart because that's a significant amount of patients. And in the 2021 survey, the majority said they learned about family planning from their primary neurology team. And that's 81% of people said that. And that is really impactful because I think we all share a very intimate relationship with all of our patients. And I think sometimes we see them more than their primary care doc. So us being familiar with this becomes very important for good comprehensive care. So I've probably hit the horse over the head several times with why this is important, but let's talk about what we actually counsel them about. So if you've ever heard me talk about this, you know this is probably something I mention way too many times during a talk, which is talk about it the first time you see a patient and talk about it every single time. So I think most of my patients, even if they go, well, gosh, I've got 2 kids, I'm not planning on having any more, all of them know that I'm going to ask them every single time until they hit 45. And I think establishing that early on takes away the awkwardness. It takes away our biases where we say, gosh, are you thinking about having kids? Should I ask you? If you make it part of your standard template, your standard of care, right, there's not much to think about, and you're doing it in an unbiased fashion rather than assuming someone might not want kids or assuming that, oh, they already have 6 kids, they probably don't need any more. I'd like to ask open-ended questions, asking what are your family building plans? What are your family planning goals? I've often found that if we ask, are you going to get pregnant? They go, no. You go, okay, moving on, which is a lot easier to do, but sometimes you might miss really key details. For example, I had a patient a few weeks ago. I said, what are your family planning goals? They said, oh, I'm not going to have children. And I was like, well, tell me why. It's totally okay if you don't want to have kids, but tell me why. And they said, because every patient with MS is going to have kids with MS. Which I was like, whoa, learning opportunity, teaching opportunity on my end. Let's talk about it. We talked about it. She's like, I still don't want kids. And I was like, great, but as long as you understand that it doesn't mean your kids are going to have MS. Shared decision-making, incredibly important and highly individualized. But the other thing I would point out here when we're thinking about inclusivity is biological sex is not the same as gender identity. So not to make, again, assumptions about our patients. So here is kind of how I think about this in my head. Here's my family planning paradigm. So starting with, again, open-ended question, what are your goals? Then branching out into, are you thinking about something in the next year? Are you thinking about something over a year from now? And then kind of going down this algorithm. So we'll break it down. So in those individuals that are saying, I'm thinking about this in over a year, really having that discussion about contraception. Now this becomes important because I said just about 49% of all pregnancies in the US are unintended. There has not been a study looking at this in MS patients. I presume this is lower, but I don't have data to support this. So something you should bring up with every single patient, every single visit, if they're not actively trying to conceive. One of the things I do emphasize is there's a difference between reliable use of contraception and unreliable use. So tracking basal body temperature, saying, oh, we use the withdrawal method, all of those things, not very reliable. The other thing, too, is if someone is using oral contraceptives, asking them, how many doses are you missing? I have someone I saw, again, a few weeks ago, a different patient, that said, well, I take them, and I said, how often do you miss a dose? And she said, well, I really only take them once a week. And I was like, okay, it's probably not doing anything, right? Just a few notes from a pharmacology standpoint. There are a few medicines that interact with our oral contraceptives. So if you prescribe modafinil, important to have counseling with patients that can decrease the effectiveness of their birth control, even if birth control is taken properly. Anticonvulsants, so if we're using it for neuropathic pain syndromes, again, also can decrease the effectiveness of oral contraceptives. And if you're using lamotrigine or you've got a patient with seizures that's on lamotrigine, oral contraceptives can decrease the effectiveness of that. So kind of thinking about some drug interactions there. So moving on to patients that say, I'm thinking about family planning in the next year. What is our checklist? And here's kind of the mental checklist that I've got. One is thinking about OB referral. So establishing with an OB early on before they get pregnant can be very helpful. One, to think about symptomatic medicines, but also to make sure there's clear lines of communication between the neurology and the OB teams. I really like to do MRI scans before my patients get pregnant. The reason for that is if a patient has a new symptom during pregnancy, we often don't do contrast or gadolinium, and I'll show that in just a few slides. But really saying, here's a baseline. If I need to get a non-contrasted scan during pregnancy, I can. And then I can just compare T2 lesion for T2 lesion instead of worrying about if I've got new enhancement and talking about the risks that come with GAD. Supplements are really no different than our average patient without MS. Smoking cessation becomes incredibly important, thinking about comorbidities. Disease stability we'll talk about in just a minute. And then thinking about, are you on a DMT that's safe? So how does MS affect pregnancy? Most cases, there's not really a huge amount of effects. Shouldn't affect your ability to carry the baby, miscarriages, birth defects. You can have a cesarean section, you can have a vaginal delivery, you can get whatever kind of anesthetic you want. And I will often outline this to patients when we're talking about our conception visit or when they first get pregnant. There was a very old paper published a few decades ago talking about how if MS patients get epidurals or spinal anesthesia, that it increases risk of relapses. And I've found that depending on where some of my patients are delivering, that might be something they're told as they're being whisked back to get an emergency C-section, and that I think is really traumatizing. So I bring this up just as no one will probably tell you this, but just in case they do, know that I think it's totally okay. What kind of negative consequences do we see in pregnancy related to MS? We do know women with MS have babies that are lower birth weight, usually not significant enough to require ICU stays or extra long stays in the hospital, but something to note. And there have been older studies that look at this increased risk of induction and operative interventions during pregnancy. It is in an older population, so hard to know, is it because those patients were more disabled, but nonetheless something that we see. Again, going back to the most common question I get asked when we're doing this pregnancy planning is, what is my risk of planning or passing on MS to my kiddos? So we know with this big genome-wide association study that was done in 2019, they found over 200 different individual genetic loci that are responsible for MS. And we know based on some older studies, the risk of a child developing MS, if one parent has it, somewhere between 2 to 5%, and if both parents have it, somewhere above 20%. But the thing I feel like resonates really well with patients is talking about the identical twin studies, where I say if one twin has it, then the chance of their identical twin having it, depending on the study you look at, somewhere between 25 to 30%. So I really use that as a point to illustrate it's not purely genetic. And even if you've got the same genes, that doesn't guarantee that you'll get MS. Here is something that most of you thought you wouldn't hear in a neurology talk, which is what are hormones doing during pregnancy? So as most of you probably know, you have a sudden increase of estrogen and progesterone during pregnancy, especially accelerated during the 3rd trimester, with a sudden drop-off afterwards. And that ties in really nicely with what we see with what's happening from a natural history of MS standpoint during pregnancy. So this was a study published in the early 2000s looking at mostly women that were not on disease-modifying therapy and saying, what were your rates of relapses pre, peri, and postpartum? So that gray rectangle illustrates the risk of relapses during the 3 trimesters of pregnancies. And what you can see is that number drops about 70% compared to where they were prepartum. And then in the 1st trimester postpartum, so those first 3 months, you see an increase by about 70% from where they were prepartum. So I often will bring this up, but I think the other thing to illustrate there is to say, well, what does that look like in more modern cohorts? And to be totally honest, looks very similar in most modern cohorts, where we still see an increase in disease activity after delivery of the baby. So if someone is trying to conceive, a quick little side note about how long have you been trying to conceive? So the definition of infertility, as defined by the American College of Obstetrics and Gynecology, is if you're over 35, if you have been unsuccessful in getting pregnant for over 12 months or over 6 months, and if you're under 35, if you've been unsuccessful for over 12 months. In MS, we previously thought that there was no impact of MS on fertility, but are starting to find that maybe patients with MS experience infertility more. In one of these studies, they found that the rates of infertility diagnoses amongst patients with MS were higher than their peers without MS, but interestingly found that the rates where they used assistive reproductive technologies like IUI or in vitro fertilization, those rates were lower. And there's a question of, do you have decreased fertility even before your diagnosis of MS? So a small study kind of looked at what anti-Müllerian hormone levels are, or AMH, which tells you about how well a woman's eggs are doing, maybe a good surrogate for fertility. And it found that even in women before they were diagnosed with MS, they had lower AMH levels. So what does that mean to us clinically? How do we counsel patients? I, again, bring this up before someone starts trying, if I'm seeing them then, just so it's not incredibly overwhelming. But in most of my patients, if they've been trying to navigate getting pregnant for 6 months and have been unsuccessful, regardless of their age, that's usually a fairly quick referral to one of my fertility specialists to really say, is there something else going on? Is there something we need to optimize? Or do things look okay and maybe we just haven't given it enough time? Let's talk a little bit about disease stabilization. So in most cases, we talk about, well, we would like 6 to 12 months of disease stability before getting pregnant. I had a conversation with a colleague yesterday who said, I like to tell all of my patients 2 years. And I think one of the things that's important for us to think about is it's great when we have guidelines, it's just not always practical. Right? How many of our patients do we see that are in their late 30s where probably getting pregnant is already a little bit challenging? And then we're going, no, you're 38, you got to wait till you're 40 before you can even start trying. And in patients that want to have more than one kid, that want to have a big family, or that have very specific family planning goals, I think it is really discouraging for us to go, you can't do this. So I think our goals are to say, how do we do this, but do it safely as much as possible while you're still able to live as much of your life in the way that you visualized it as possible. So how do we keep patients safe? I mean, we really talk about counseling, right, being incredibly important, but I think considerations of disease-modifying therapies, which I'll talk about in just a second, I think becomes integral in allowing patients to have this flexibility. As I mentioned earlier, integrating the OB into the discussion before someone gets pregnant, if possible, to talk about symptomatic medicines is really helpful. But let's focus most of our time on disease-modifying therapies and what kind of planning we can do. So going through the injectables, both glatiramer acetate and interferons have extensive safety data with no reports of fetotoxicity. So likely interferons can be used up until the time someone conceives. Glatiramer acetate can probably be used safely throughout pregnancy. With the oral DMTs, easy thing to remember is oral molecules, oral medicines are small. Do not use them during pregnancy, and that's true for all of the oral DMTs. So for cladribine, you'll hear me kind of talk about what is in the prescribing information and probably what makes sense, thinking about real-life pharmacokinetics and dynamics. So for cladribine, the washout is 6 months, but probably could be shorter, just given how fast cladribine washes out of the body. The fumarates, no evidence of fetotoxicity with our fumarates, but again, not taken during pregnancy. Teriflunomide, there has been animal evidence of fetotoxicity, which I'll talk about in just a second. And then also our S1Ps, one of the things that's important to think about is what is this risk of rebound disease activity? So let's talk about teriflunomide first. I'm sure most of you are very familiar with this black box warning, which outlines really those risks of embryo-fetal toxicity. And they really illustrate, well, if you accidentally get pregnant, you need to do this accelerated drug elimination protocol, which is usually cholestyramine or activated oral charcoal powder. And this becomes important because if you just let teriflunomide wash out on its own, it can take about 8 months to get to undetectable levels. However, one of the things I might point out, which is not me advocating for putting all your patients that are planning pregnancy on teriflunomide, but there have been 2 studies that looked at outcomes in humans that said, well, what happens to these infants? Do we see higher rates of X, Y, or Z compared to the general population? And interestingly, in both of those studies, there was a higher rate of elected abortions, I think, than we see on average, but really the birth outcomes in terms of birth defects and miscarriages were actually very on par with the general population. So it brings to mind, well, gosh, is that black box warning warranted? Hard to know. Is there any way that's coming off the label? Probably never, but something that's important, and I think if you have patients that get pregnant on it, important to let them know about. With fingolimod, so I'll say this as the one S1P that we have the most data with in pregnancies, so we don't really have them with the other S1Ps, but with fingolimod, really we think about that rebound risk, that increase in disease activity after cessation being somewhere between 5 to 10%. In pregnancy or in pregnancy planning, it's a little bit harder to quantify just because there aren't big studies about it. So a lot of it from case series or case reports. But I will illustrate this was a young woman who was doing fairly well and then became locked in septic in her first trimester of pregnancy after fingolimod cessation. So I think things to think about if you have a younger patient that is planning on pregnancy planning that's on one of these oral agents, it's not one that you want to abruptly stop. And all of my patients that are on S1Ps, when they think about family planning, I will usually transition them to another medicine to mitigate this risk. When we think about the infusible DMTs, so here really talking about the anti-CD20 therapies, depending on the medication, whether it's the sub-Q or IV formulations of CD20 therapies, their half-lives are different, somewhere between 16 on the shorter end and 28 on the longer end. One of the things I'll point out is when we go through pregnancy, these medicines, because they're larger molecules, unlike our small oral molecules, the larger molecules need a transporter to take them from maternal circulation to infant circulation. Those transporters on the placenta don't develop until weeks 16 to 22 on average. So important things to keep in mind is, well, when does my drug eliminate from the body? What are my 5 half-lives? And how does that relate to when these placental transporters develop? I will say prescribing information says somewhere between a 6 to 12 month washout with 12 months for rituximab and 6 for the other 3. So this, I think, is probably a better paradigm for how we can use CD20s during pregnancy. And this is probably what I use the most, which is really thinking about when someone gets the medicine, how long do they actually have to wait for that medicine to wash out before there is risk of transporting across the receptor? I will often counsel my patients and say, here's what's FDA approved, and here's what we could use in theory based on some of these metrics. And I think it makes it a lot easier and a lot less stressful if we say you have X amount of months to get pregnant, good luck. If you're not pregnant, then we need to figure something else out. I think this gives us a lot more flexibility. We will probably get some more data, at least from ocrelizumab with the Minori and Sopranino studies coming out too. From the infusible medicines, alemtuzumab 4-month washout should not be used during pregnancy. And with natalizumab, again, larger molecule, and we really say, well, can we use this safely during pregnancy? And I would argue we can. We just have to be a little bit more cognizant about it. So really the main risk with natalizumab use during pregnancy occurs in that 3rd trimester, which is higher rates of infant thrombocytopenia and mild anemias that have been detected, most of which resolve on their own once an infant is born. So what my treatment paradigm usually is with natalizumab, again, knowing that the PI recommends a 6-month washout, what my treatment paradigm is usually to consider extended interval dosing, so every 6 weeks as opposed to 4, during the first 2 trimesters, and then stopping right at the start of the 3rd trimester, and then resuming shortly after delivery. If you do treat throughout all of pregnancy, I would recommend checking an infant CBC with delivery. Now the question might be, why don't we stop earlier, right? We talked about how this could get to the infant. Why not stop in the 1st trimester or when you find out someone's pregnant? A really nice study done out of Germany by Dr. Helwig's group showed that 11% of women that stopped natalizumab right before pregnancy or in the 1st trimester had clinically meaningful disability 1 year after delivery. And 11% is not an insignificant number. And this is something that's illustrated again in this algorithm or this picture, where you can really see the amount of patients that needed wheelchairs, canes, or other assistive devices really increases dramatically. And I think all of us would agree, we put patients on these highly effective immunotherapies to prevent them from getting to that stage. So it doesn't make a ton of sense to do something that might potentially worsen them. So something to keep in mind. When we're thinking about peripartum relapses, as I mentioned, MRIs without contrast are safe during pregnancy. There is higher risks, including the risk of stillbirth with contrast use during pregnancy, so I do not recommend that. In regards to steroids, most OBs are actually okay with steroids during pregnancy. There is a slightly increased risk of cleft lip, cleft palate during the 1st trimester of pregnancy if steroids are used, but I don't know that that's been completely substantiated, but something to talk about with their OB doc. So when we think about the postpartum period, we talked about that higher risk of postpartum relapses in the first 3 months, and really thinking about, well, what increases this risk? Things that increase that risk is how stable was your disease before you got pregnant? How stable was your disease during pregnancy? What kind of medicines were you on before pregnancy? How disabled are you? We found that the folks that went into pregnancy with higher EDSS scores were more likely to have postpartum relapses. And then also, were you breastfeeding? And we'll talk a little bit about that. I would really closely monitor these patients for postpartum anxiety and depression. There are higher rates of this noticed in MS patients postpartum. And then also thinking about our comprehensive functional evaluations, looking at sleep, looking at bowel, bladder. Do they need physical therapy, whether it's physical therapy or pelvic floor therapy, or even some of the speech language pathology therapies for cognitive evaluations. We do know breastfeeding has a positive association in terms of relapse reduction in MS. In this study, they found breastfeeding was associated with a 43% lower rate of relapses compared to not breastfeeding. Now, I bring this up, and again, talking with our patients, if you want to breastfeed, great, there's this data. I don't think you should go out of your way to breastfeed if you don't want to breastfeed just because of this data, because in most of those cases, we can start people on DMT sooner. So bringing this up, but again, I think kind of thinking about it in a non-assumptional way really allows us to have the best communication with patients here. I bring this up just to talk a little bit about medicines and how medicines are thought to be safe or not safe during breastfeeding. So when a woman first starts lactating, she makes colostrum. It then turns into transitional breast milk and then mature breast milk. Now this is important to know because what we know about all of these drugs getting into breast milk is all based on the guise of it being mature breast milk. Mature breast milk in most women will be there around days 10 to 14. I usually wait the 14 just to be extra cautious. But thinking about this, and this is something I tell all of my patients about too in terms of why we start DMT and the points that we do. So again, going through the same safety data that we know about DMTs, but thinking about it in breastfeeding. With all of the injectables, really probably okay to breastfeed. Their large molecules don't really readily pass into breast milk. Same concept we thought about for pregnancy. Oral DMTs are small molecules, easily pass into breast milk, so I would not recommend actively breastfeeding while on an oral DMT. With the infusibles, now again, larger molecules, less passage into breast milk. So we really know that from just a generalized standpoint, we talk about this thing called relative infant dose, which says how much drug is in breast milk relative to how much drug is in mom's bloodstream. And we know that the FDA considers these levels less than 10% to be acceptable. So thinking about these infusible DMTs, really the relative infant dose that we know about is low in all of them. But you also think about infants are taking breast milk in by mouth, so likely to create destruction of those medications. So with natalizumab, those RID numbers, the relative infant dose, very low. And time to peak after first infusion is usually in the week afterwards. But interestingly, they didn't see an increase in breast milk concentrations as you get more doses of natalizumab. So in most of my patients with MS that are breastfeeding, again, we discussed that the PI doesn't recommend breastfeeding or doesn't recommend that you're allowed to. But thinking about some of this data, probably okay as long as we're waiting at least past that 2-week mark. With CD20s, again, thinking about larger molecules, RID was less than 1% in most studies, with maximal concentration similarly in that first week post-infusion. This is a study we did where we had our moms that were breastfeeding on CD20s check their infant blood counts to see, well, hey, is there any impact on infant B cells? We know infant B cells become incredibly important, especially because they're getting so many vaccinations those first few months of life. And what we found, I think, was to no surprise, which all of those infant B cell counts were normal. Okay, in the last few minutes, we'll transition over to menopause. Kind of thinking about prevalence of menopause, and I know we're going on a whirlwind, and I appreciate you staying with me. If we think about our general MS population, the last estimate estimates about 30% of women with MS are either menopausal or postmenopausal, so really important things for us to think about. Menopause does not seem to change in patients with MS in terms of age of onset compared to their peers without MS, and so that average age is around 50 and a half. And one of the things I illustrate to most of my patients that are going through menopause is one of the beautiful parts about aging in MS is your immune system becomes less inflammatory, becomes less active. So around the time that most women are going through menopause, you see this concomitant immunosenescence going on. So the data in menopause is a little bit contradictory. So there's been a few studies, as illustrated here, that say, well, is there a mild increase in disability progression after your final menstrual period? So really looking at what did patients say in terms of how they feel, what did their EDSS look like? But what I would point out is this is not always observed. So in some of the studies, it goes, EDSS levels didn't change. People might have reported a slight increase in cognitive issues or more Uthof's phenomenon with their hot flashes, but then after menopause was done, they went back to their baseline. So I think the question becomes, well, what do we do? What do we do as neurologists, as their care team? And I think the biggest thing that we can do, and this is probably something we should do at all points, but really important during menopause or perimenopause, is really saying how do we optimize the symptoms that are getting worse, because we know increased disability, increased symptoms in patients with MS, and this is, again, at any point in time gets worsened, gets amplified by suboptimal disease symptom control. So really thinking about how do we optimize cognition? Are there factors there that are playing a role? Like I'm not sleeping well because I'm having hot flashes. Me not being able to get my REM cycles is leading to more short-term memory things that is being amplified by menopause. Or I'm getting really anxious, and when I'm anxious, I feel like I'm not thinking well, right? So all of those things, thinking about how do we delve deeper into symptomatic management or even optimize symptomatic management during this time, I think is something that we should all focus in on. I will point out that just about a year ago, there was an FDA-approved non-hormonal medication for hot flashes approved called Veozah. I've had quite a few patients that are on it. I don't prescribe it myself, but their gynecologists do, or primaries. But I think it really helps with the reduction of that Uthof's phenomenon, or that worsening in the setting of heat. We all know that MS patients' symptoms can worsen just with a 1/4 degree increase in body temperature, and with hot flashes, it's a lot more than just a 1/4 degree increase in body temperature. So really saying, how do we optimize, again, and reduce those things that are making you feel worse? And I think the question of HRT, or hormone replacement therapies, is probably one you've heard scattered throughout the Congress so far. But really thinking about, I think there was a lot of probably poor data in the past looking at HRTs just as a whole, and a lot of probably bad visualization or bad advertising. And so I think one of the things that we'll start seeing is hopefully our women with MS are able to be on HRT doses safely. What I would say, especially kind of thinking about from our angle, we're usually not prescribing hormone replacement therapies, but recommendations I often have to my patients is make sure you're seeing someone who's certified, who knows what they're doing. So I usually say someone with a certification in gynecology. I usually recommend my patients do not take pellets, and pellets seems to be a really popular thing, at least in Denver where I live. There's been a statement that was put out by the American College of OB-GYN about a couple of years ago just about inconsistent hormone releases with vaginal pellets. And so if nothing else, I usually talk a little bit about staying away from those things and thinking about the pills or the patches if you're doing estrogen replacement as being a safer option. So I will thank you for going on that whole whirlwind, and happy to take any questions if we've got time, Connie. Yeah.
When a woman wants to get pregnant and sees you, so what is your favorite DMT, and what's the timeline that you do it? I know that people do it differently.
Yeah. So favorite DMT is a loaded question. I will say it with that. I think there's benefits to doing different things, and I think, and I didn't talk about this, but there's a huge psychological component that comes with all of this, especially like family planning and thinking about, instead of being spontaneous, you have to like plan, and I think that doesn't help the stress levels of most patients. So depending on my patient, I'll think about it a few different ways. If I have someone that's totally treatment naive, I often will go to the CD20s, and which one I choose depends a little on the patient. I've got some patients that go, I really want to compartmentalize my MS. It's not something I want to think about every day. And I go, okay, infusions are probably a better choice for you. And in those cases, I usually say, get your infusion, wait a month, and then go ahead and start trying. Try for 6 months, so you're a month late on your infusion. Try for 6 months. If you're not pregnant, by the time you're at that 7-month mark, I have them take a pregnancy test. As long as it's negative, get the next infusion, and that's often where I'll trigger my reproductive endocrinology referral. Now with like an injectable CD20, like OFA, I think one of the things, because its half-life is just a lot shorter, it's only 16 days. So what I will often do with that, as long as my patients have a regular menstrual cycle. A little bit hard if they're coming off oral contraceptives. But if they've got a regular menstrual cycle, I'll have them actually time their Kesimpta with their menstrual cycle and say, when you get your period, take your dose. And if you haven't gotten it, take a pregnancy test. If it's negative, then take your dose. And I think that's probably one of my favorite strategies for my what we call geriatric pregnancies, which is a terrible term, but our older women with MS that are trying to get pregnant, because I think it gives you a little bit more flexibility. Because I think if we look at those PIs, we go, okay, you had these doses, now great, be off for 6 months. And then what are you gonna do? Try for 12 months, and then you're infertile, and then you go see someone, and then you take your medicine, and then you have to wait another 6 months. I think it's just kind of impractical. Yeah.
Thank you.
How long do you wait to start natalizumab in a patient who wants to breastfeed?
I usually wait 2 weeks. Any other questions?
So when it comes to the breastfeeding, when you said that there's a decreased risk of, I don't know if it's relapse or disease progression in patients who decide to breastfeed, what timing, is it 3 months of breastfeeding, 6 months, a year? What is that time frame?
Yeah, it hasn't really been totally elucidated. I think one of the things that's challenging too is it's hard to know. So those were in patients that were exclusively breastfeeding, meaning no formula supplementation. And I think the other pitfall there that we don't know is if someone's breastfeeding some, but also formula supplementing at other times, either because they don't have enough supply or just from a lifestyle standpoint it doesn't work. I think we don't know. My presumption, I mean, that's really looking at the first year. Hard to know if all of those patients were fully breastfeeding or exclusively breastfeeding that whole first year. But I think one of the things that's nice, at least with some of the newer data that's coming out, is I don't think it has to be one or the other in terms of breastfeeding versus treatment. And I think doing both synergistically probably provides us optimal success. Yeah.
Tricia, you want to come so you can get your slides up? Okay. So what should I tell you about our next speaker? We're actually old friends. And you're going to get it. She has to come out. Let's see. Yes. Let's see if you can exit out of that. Interesting. Oh, go up. And then you go close. Yeah, go down to close. Yeah, and then you can click on that. Okay, so Tricia Pagnotta and I, again, are friends. How many years ago did we meet? Tons of years ago. We were both working in MS. She actually works now at the MS Center of Greater Orlando as a nurse practitioner, but she's also a researcher and has published a number of articles on research and has been primary investigator in research trials. She graduated with her first degree in nursing in 1981 from the University of Maryland. She moved to Orlando and then went to University of Central Florida, where she received her her master's degree, and is now practicing as a nurse practitioner. What she really loves first or second is maybe her husband's first and her grandchild is first, but she's an active horse rider. She has show horses. She moved out into the country outside of the Orlando area, and now she has raises horses and keeps horses, don't you? You have stables and all that. So she's a different person now than she was 10 years ago, but she's a wonderful person, a wonderful caregiver, and I think you're going to enjoy her presentation. Okay, darling.
Well, thank you, Connie. And Connie and I have known each other for a long time, and when I hear that, I just think, oh my gosh, how old I'm getting. But anyhow, and so I encourage all of you, one of the things I want you to know is one of my pitfalls is that I have always been an individual who runs overtime. So I made my slides very short so that we would have some time to talk, because this is a talk that really is best lent to being able to have discussion about some of this. So I'm going to lay the groundwork, and I hope, since so many of you hung around, that we'll be able to have some discussion. And when I listened to Dr. Shaw's talk, I just thought, oh my, she left so much on the table for me for this discussion that I'm about to have with you. So anyhow, and I think that, as Connie told you about my diversity now, that's something that we need to think about when we're having shared decision. And Dr. Shaw pointed out that several times. We cannot make assumptions about individuals. We can't make assumptions that people don't have different lives and think differently than we do. And that's a core of shared decision making. It's a collaborative process in which the patient, the healthcare provider contribute to medical decisions, with the patients being full partners in their decision about their care. So agenda setting is important. We have to elicit the patient's preferences. We have to tailor information somewhat related to that. That was in the literature, but I don't, when I think about shared decision making with patients with MS, they are so much more educated than some other disease states that I treat. I really throw it all out there and then have a discussion about that. But encouraging patients to have deliberation. So you have to be very careful as you throw it all out there, because they can't deliberate about all of that. And then delineating choices for them, or helping them delineate choices. So some key concepts in shared decision-making is there's this predominant thought about the self-determination theory. And there's two components, really, of this. And there's one that is a controlled motivation. And that's really that a motivation that results external to the individual themselves. So either they have a sense that they need to do something because of a cultural way that they were raised, or maybe a guilt, or somebody else maybe is pressuring them to make this type of decision. The other is a more autonomous motivation, and that really is something that is volitional, aligned with the patient's values, and consistent with their perceived competence. And so that's important to think that patients who do better with shared decision-making, it meets their three basic human needs. And their three basic human needs when it comes to shared decision-making is really competence, the ability to be related, and then the autonomy. And so when you think about some of these, the difference between autonomous motivation, well, controlled is more, the patient is not really going to be as open as we might think because of their external pressure. But in autonomous motivation, that doesn't necessarily mean that the patient makes the decision. That means that the patient directs how the decision is made. In other words, there may be individuals that come into your practice and you go through this whole saga of here's all the choices that you can make, and you run through every single one of them. And you educate them all, and you kind of help them well with your risk factors or your prognostic indicators and this, that, and the other. And then you say, well, what do you want to do? And they may find that to be offensive. So you have to, again, be sure that their autonomy, their wanting to make a decision, is something that they want to be wholly part of or partially part of. Because if you ask them to make a decision after you've done all this educating and don't give them enough guidance, then that becomes internally offensive to them. They want, if they're saying they want you to be a partner in making this decision, that is ideal for us and ideal for them, but the key is how do they feel about this? And that we know at least we believe, we haven't proven in all studies, that patients are more likely to be adherent, more likely to be satisfied in those type of strategies. The other part of shared decision making is a model where you're looking at the complexity of the decision that needs to be made versus by the motivation of the individual. So if you have someone who is in the middle of a relapse and is doing very poorly, and then you try to educate them at that moment about relapse management, they're probably going to, most of the time, defer to what you may think. And so that, again, could be autonomous in the fact that they deferred to you, but the reason they may have done that is because they were in such a bad situation and they had such a low energy level at that moment, they could not possibly give as much to that as maybe they would have if they had had that education prior to a relapse. And so, again, the important thing is there's varying level of patient conditions and provider behaviors and communication styles, and it really, you need to think about how that fulfills a patient needs. And so this is one framework that I found out there that kind of looked pretty simple to me. There were some other frameworks out there that were very complex, but this really looks at, you know, the patient in the leader of, and you're eliciting their values all the way through, and through those values, you're going to come up with their goals. And there is the care provider in there, and that's important that many patients will want to have their support person with them. But you notice that that care provider is not the same thickness as the patient. And that might be something that we need to navigate. That, you know, I have had care providers or care partners that come in and want to take over the show. And so you really, in shared decision making, you're making a decision with the individual who is affected. And we could argue whether or not care partners are affected, but they don't have the disease, okay? So the first step is really soliciting all their values, their goals, making sure you have that. And then step two is really moving into showing them the pros and cons of their decisions. I mean, I think Dr. Shaw elicited that several times in her talk about, making sure a woman has the information she needs to make about making decision. And so the same thing is with any, whether it's a symptom management medication, a disease modifying medication, patients have the right to understand the pros and cons, and that may include choosing not to go on a medication. And then from that, they move into hopefully a personal discussion and decision, and that will then hopefully meet their goals. Now, again, in this circle here, they don't elicit what is going on, but the provider, again, the framework here I got from an article, so it says physician there, but I would tell you the provider could be any healthcare provider, is helping sometimes based off of where that patient is with not only expressing the education about pros and cons, but also helping them with when they ask questions about what would be your opinion, what would not be your opinion. As long as they're eliciting that information from you and you're not, part of shared decision making, some of the behaviors can be motivational interviewing. That can be a strategy at trying to help an individual. But if you're using that motivational interviewing to really get the patient to move to where you want them to go, then that truly is not shared decision making. So truly in shared decision making, you're educating, you're informing a patient, and you're helping them to the degree that they want to be assisted. So in looking at the gaps in shared decision-making, specifically in looking at patients with multiple sclerosis, 91% of persons preferred to make an autonomous shared decision. And again, this, I leave you with, this was a survey of patients, and so I can't tell you what that meant other than their perception of autonomous and shared decision. Only 9% preferred for the provider to make the decision for them. What we don't know sometimes is, are patients really getting what they need to make the shared decision? And studies on that, patients tell us that their needs are far outmet as far as it comes to education and their desire to know about the symptoms, prognosis, and management. They really feel like, and I'll say again here, provider is not giving them the information that they need. They feel like that they don't have everything they need. And I wonder sometimes, is that because the decision is being made too quickly? I mean, we're all very motivated to get an individual on a treatment as quickly as we can. And depending upon where you live, that may be even more motivating for you if you know that, well, once we make a decision, it's going to take me a month to get it from the insurance company or more. So again, we have to be cognizant that patients need to have their needs met as far as education and where their disease may go and whatnot. So looking at education programs in individuals who have had MS, there was a study looking at a relapse management program where individuals were educated about relapses and the side effects of steroids, both, and there's a typo here, sorry, about IV or oral steroids, and this was long before they had a relapse. And 78% of those individuals decided either not to use anything or to use an oral steroid. So that is, again, assumption that we make if we haven't had this discussion before, that most individuals that in my area, they go to a hospital and the emergency room physician immediately gives them steroids. And, you know, so that's something to consider. And urgency treatment, patients who received more information, urgency of treatment, did not show an increased anxiety or depression. And so many individuals say, well, this is just too much for a patient to handle. They can't, you know, but studies say that that's not true. A Cochrane review of MS patients said they really can handle this complex information, and they can make decisions. And so that's important to keep in mind, that individuals can absorb this information. When we looked at another program looking at MRI education, and this was not as much geared to shared decision-making other than being able to share information, that patients who were given an online program of a study looking at MRIs, increasing their knowledge about MRIs, they then had more confidence, reported more confidence in discussing their MRI with their healthcare professional. And so, you know, leading from that, could that then help them better make clinical decisions? There is a committee or standards for patient decision aids, and so there's a high criteria for what is considered a quality decision tool, and here are the things. It has to be systematically developed in a very process-oriented. It must clarify and express the individual's interest. Disclose any conflicts of interest. So I don't know of any of us who work for a pharma company, and so that would be maybe, you know, but if you are doing a study, and I do a lot of studies in my office, so I have to, you know, tell them, well, the study, we have studies here. And then when I ask them to think about that, I leave the room. They make that decision with our research coordinator. I present the option that if they want, but I leave the room because that is a huge conflict of interest. It must be in plain language, things that they can understand. It should not be in such medical jargon that they can't appreciate that. And it should provide them clear options, information about the choices that they might make. Oftentimes, and they say for the highest quality, you should have patient stories. So again, become more relatable to an individual. It should be delivered on the internet, so patients should be able to access this. And it should be with the latest evidence-based scientific data and established effectiveness. Now, this is not established effectiveness for the therapy that you are making it, if this is a disease-modifying therapy. So you don't have to, because there is not a fully established efficacy that we could put out there publicly. So it's just a guide for what has been seen in clinical trials. Present probabilities, and guide or coach them in the deliberation and communication. And it should be balanced with options. So patient decisions age are meant to be supplemental to encounters, not take place of encounters. And some individuals are quite worried that, if we do shared decision making, well, what am I there for? And that's not the case. It should help patients develop an accurate risk perceptions when presented with probabilities. It should help patients select an option that is congruent with their values and reduce decisional conflict as they report being more informed about their choices and more aligned with their personal values. And studies on decision aids in MS have not shown any cost effectiveness in implementing decision aids. So that's a drawback for us. And so looking at some other limitations, studies are mixed as to whether or not this helps with patient adherence. So we think naturally if patients are more engaged in their decision making about what they do, that it will help with their adherence. Well, the studies have yet to prove that. And studies have not demonstrated it improves their outcomes. So again, I think that's tied to the fact that sometimes, there are many things that, irregardless, their people may have bad things or worse outcomes. And looking at a Cochrane review of decision aids, looking at the time, and this is something that I found quite interesting because many of us talk about the limited time we have in an appointment, and that is very short. And if we have to go through all of this, how long is a visit going to be? So that's one of the things that I hear when I'm talking to individuals about this. I don't have time for that, and really, it only on average, some people 8 minutes shorter, and some people 23 minutes longer, but on average, about 2.5 minutes longer in an appointment. The reality is, though, insurance companies often take this out of our hands because whether the patient wants to make a decision or we want to make a decision, the insurance company has a decision they want to make. And so the best thing we can do is when a patient makes a decision, just like as if we had made a decision, is help fight through that process for them. And then shared decision making really does not have enough literature in low literacy populations or in cultures where they didn't speak the predominant language. So that's something to be quite aware of. So looking back in some of MS data in a NARCOM study of over 7,000 patients, Females preferred shared decision more than males. And in a meta-analysis of 775 clinical encounters in 7 US-based randomized trials across several disease states, gender didn't make a difference. So that is, we don't know about that. There's been no studies in non-binary patients. And then there was another NARCOMS survey, and again, they thought that younger patients more were wanting shared decision-making than older patients, but there was no clear delineation of what was old and what was young. So depending upon where you stand, age is a big difference. I don't think I'm old, but some young people think I'm old, and so who knows? But that wasn't clearly defined there. And then there was a look at almost 64,000 individuals in this US-based medical expenditure panel survey, and they reported that Hispanic, Asian Pacific Islanders, Black African American patients had poor satisfaction when it came to shared decision-making compared to white individuals. They also found that lower education level was associated with a poorer shared decision-making satisfaction. And patients with higher disability had less preference for shared decision-making. Things to keep in mind. And this is a very busy slide, and so I hesitated putting this up here, but this is the largest study to date in a decision-making aid, and I don't see Kathy Costello and Dr. Scott Newsom were integral in helping with this. This came out of a grant through several companies, but out of the MSAA. It's called MS Support. And so it's very readily available on the internet. The study was done between 2019 and 2020, so right before the pandemic. But they recruited many individuals, and of over close to 600 individuals, only 203 patients completed the survey, and a lot of that, there were many things that went into that. There were 34 different prescribers that were involved in this, and a call out to us mid-levels. The majority of those, 53%, were mid-level providers. And of that 53%, only 12% were physician assistants. And I only say that because I think we need more physician assistants. If you were to poll the mid-level providers, I think that's in line with, so I don't want you to read that and think that, but that was kind of in line with what I would think our population of physician assistants compared to nurse practitioners were. But this is a tool that goes through a very rigorous decision-making tool for patients, all along eliciting their opinions about, how much do you want to, how much decision-making do you want to do here? What do you think of your disease? It looked at their ability to get in and out of appointments, all kinds of medications, family planning, their age, their preference on worsening disease, misleading information. It went through many things, so this could be used for not only decision-making in disease-modifying therapies, but could be used for symptom management therapy, although the target of this study really was looking at making decisions based off of, for disease-modifying therapies. And it was very positive. So they reported that there was an increased time to getting an individual on a disease-modifying therapy, that people that were in this study went on disease-modifying therapies sooner than people who, the placebo-controlled trial, and the usual care component. And then there were some people that were not on disease-modifying therapy. and they chose to go on disease-modifying therapy after this. So there was also, patients reported that this was the best thing. They were all ecstatic with, there was close to 90% extreme satisfaction in using this tool. And this looks quite complicated, but just as a process for you, this was sent to individuals prior to their appointment. Again, has to be internet-based tool. So this was sent to individuals prior to their appointment. They were able to use this to prepare for their appointment. And then the provider had this available at the time of appointment to really hone down on and help the individual. So it was quite satisfactory for patients. And they did report, and if you go to the article, there was quite a significance in adherence to medication. So I think that, as I told you before, the previous studies had not linked this to adherence, but this study does link this to adherence with disease-modifying therapies. And they also said that it was linked to better mental health for individuals. So these were people who, some of them were new to MS, some of them had had MS for a while, and some of them were stable and they weren't needing to make any decision. And so that's something to keep in mind in the people that were in this study. But the results that they got were tremendous. There wasn't anything that turned out to be negative. And from the providers that used the tool, there wasn't any negative feedback from providers that they felt that this was cumbersome. It added to their appointment times. It made their decisions more, their conversations more complex. They all were very happy with this too. So I think that this is, I even checked this morning, and it is not yet up on the MSAA's website, but I anticipate as if that grant gets extended, that this will be on their website. Right now, they have the MS Manager, and so that is an app that people can get on their phone. It kind of goes through a lot of different things, but is not a decision-making tool. But this is promising for us to look at in this regard as to decision-making. So other factors that may influence shared decision-making. So depression is a big part of MS, and we recognize now that depression is not just a emotional state that is part of, we know it's part of the damage that's going on inside the brain that is causing individuals to become depressed. But individuals who are depressed are less likely to want to have engagement. So that's something to keep in mind. Health insurance and financial situations, again, oftentimes that kind of negates shared decision-making. But again, I think if we do as much shared decision-making about as many things as we can, pregnancy planning, whether how to talk to them about getting on with a wellness program, how to talk to them about any of the symptom management medications that we want to prescribe. Because if you really start using this, you'll find, at least I have found, oftentimes when I go through all the pros and cons, sometimes patients will say to me, well, I don't want to try that. You talked about these other things, these lifestyle things I could do. I want to try that first. And if that doesn't work, but then we have come up with what is their goal and how are we going to track that. So that's one of the things that is important for me when I'm doing shared decision making is, okay, I have their goal, I have what they're going to do, and how are we going to measure that? That comes from what they tell me as did they meet their goals. Again, there's other things, spiritual beliefs. Again, that goes back to more some of that controlled motivation. There are individuals who I have met along my way that will not consider certain therapies or certain things because of their religious background. And the important thing is to recognize, I think, no matter what kind of decision you're making, is that we see things sometimes often very different than how our patients see things. You know, when I look at when I've looked at some of the NARCOM studies and different things about how patients relate some of the symptoms of MS and disability markers, how they relate them or rate them on a scale of 1 to 10, I think, man, if I had MS, that would be number 1 for me, whereas they may have put that as number 10 for them. And so in this German study, patients reported swallowing and vision was a higher problem, whereas healthcare providers thought it was the hand dexterity was more of a problem. So that's just an example to keep in mind. So I have a case for you in case nobody wants to start talking, but I do have a case. This is a real live person that came into my clinic. She is a African-American female, 32 years old. She's married. She does not have children yet. She's employed as a patient care tech in a local hospital on an adult unit. She happened to work night shift because she was going back to school. She wanted to be a nurse. 2 years or 11 years prior, she had a Bell's palsy, and she had made a complete recovery from that. She just pointed that out as part of her history. Her BMI was 32, but she said that she had been stable with that BMI for more than 2 years. She was a non-smoker, no drugs, no alcohol. She consumed caffeine moderately, she said. Again, she was enrolled in a nursing program. She presented to our clinic 1 week after discharge from the hospital. And what took her to the hospital was a right arm and leg numbness, and a week later it spread to the left leg. And so at the point that it was both legs, she thought, I should go to the emergency room. Again, we take patients where they come. She had MRI that showed that she had 2 non-enhancing lesions. She had a cervical enhancing lesion at C2 in her left hemicord, and she also had a non-enhancing lesion at T8. Now, again, she left the hospital after they had given her steroids for who knows what they told her, because she had no clue what her diagnosis might even be. But she didn't have the labs. So, of course, when she comes into me, I'm able to access the hospital, and she had CSF that had 4 olloclonal bands, and all of the other mimics had been done. Her exam was normal with the exception of decreased sensation in the right upper extremity, so she really had recovered quite nicely. So she made her appointment because she had an abnormal MRI. So I can't tell you enough that this individual left that hospital with no clue what her problem was. And I don't know what to think of that, but that's what it was. But she did know that they did a spinal tap on her, and she didn't know what they were looking for out of that. So when she was told her diagnosis, she became quite emotional, like many individuals do, but more emotional than I've seen an individual quite recently. And you know, her husband tried to calm her down, telling her, we just need to move forward, you know, and his language to her was a little bit, in my perception, condescending, but he just tried very hard. You know, stop crying. Why are you crying? You shouldn't be behaving this way. We just need to move forward. And she was unable to ask me any questions. She was in such a state of shock. So I gave her some information about disease-modifying therapies. I gave her this 1-page thing I have of all the therapies listed and how they're given and monitoring and side effects and whatnot, and gave her some reliable websites and our center's information. And I said, we just need to talk in 2 weeks. I'm going to bring you back in 2 weeks, and made sure she had access to her portal. And then we went from there. Anybody's thoughts as to how they would approach this patient at the next visit? Anybody want to? Yeah, it's an open, I wanted people to be, but if nobody wants to, I'll tell you what I did at the next visit. So again, part of what she had shared with me in the first visit was she didn't have not have children because she didn't want children. She didn't have children yet because she had a goal where she wanted to be as a professional. She had come into the United States from the islands, and her desire was to become a professional, and she was working as a patient care tech just to getting through school. And she was working night shift to be able to do that because she could work full-time nights and go to school full-time. So in my mind, I'm like, oh my gosh, she must have been exhausted. But anyhow, that was her goal. And so in thinking about her, I mean, I needed to talk to her about many things. Obviously, in my mind, Black female, all areas of her central nervous system. Although she had made a good recovery and she's middle-aged, I still consider her prognostic indicators high. And she had lots of goals. So, part of was, here's all the disease-modifying therapies. And when I do that, I've gotten down to, well, let's talk about mechanisms of action first. And then after that, we nail down to, okay, individual ones. And so trying all the way along to elicit, okay, what kind of health care insurance you have, what are going to be the financial indications for this for you, what can you do working full-time and going to nursing school, and what might, your future look like if we choose a drug that might not be as effective. And so those are some of the things. And then she didn't live anywhere. I said she was in a local hospital, but that local hospital is a hospital system. The hospital she was actually admitted to of that system was almost 2 hours from my office. So coming back to my office was not something that I could anticipate that she would want to do too frequently. And yes, that was one of her things. She worked in a big system, and she wanted to be treated closer, but there was no MS specialist closer. And when she got the referral out of that hospital, she got referred to us, but they didn't tell her that they thought that she might have MS. And my thought was, she probably may have had some level of this emotionalness in the hospital. And what I often find in some of the smaller little community hospitals, they don't want to deal with that. Get out. We have done what we can do for you, so now go see this other person. They don't want to get into the nitty-gritty. So, the other thing was for me, was stepping very carefully on that husband. Because I, again, found him to be somewhat trying to calm her down, but at the same time I found he be a little bit controlling. And I wanted her to make more of this decision than I wanted him to make this decision. But yes, he needs to be involved. MS does affect the whole family, but I wanted to get more information about what she wanted and what was good for her before having him start talking. So when I do that, part of what I do is I'm standing here at a computer desk or sitting. The patient is on a bed here, sitting most of the time on that bed. They don't usually lay down in my office. They're sitting on the bed. And then the person who is with them is on the other wall over here. So when I want that person to be quiet, I can't tell them to be quiet. But what I do, very bad for charting, but I get up and I walk in front of the patient. So the support person is actually behind me. And most people, when they're standing to my back, will be quieter. And then when she has told me all the things that she wants to tell me, I may turn around and ask that individual, well, what do you think about your wife is saying here? Or can you support this? Because it is important that, he's a very strong individual himself, so he has to be willing to support her. So there was that small little caregiver support person in there. So we can't ignore them, but I don't want that individual to take over the appointment. And so, ultimately I felt like the patient made the decision, although, again, I would say that was more a difficulty motivation type of situation, because although she was much calmer and much more controlled and had more questions when she came back the second time, it was still very emotional, and she still several times asked me, "What do you think?" When a patient asks you what you think, and you've educated them fully, you can give them an opinion about what you think, because that is part of, in my view, part of our job in educating a patient. We have history. We've seen patients, and so you can just say, based on my opinion, like we would say if we are talking, based on my opinion and based on my experience with patients, here are the things, here are the top of the choices that I would be thinking might be good for you, and let's talk about those. And so, again, and then my first thing was, getting her to commit to a disease-modifying therapy. And so I could get that paperwork moving, because that was going to be a process. And I brought her back the next week to go on talking about other things as far as where she was going to get that therapy, if there were any symptoms, and going through some other lifestyle things to make sure that she recognized some of the lifestyle things she already had were not working very well. I mean, she was getting very little sleep. She was not eating well because it was whatever was available. She wasn't doing any cooking anymore. So there were many lifestyle things that I wanted to have discussion with her about. Anybody want to share anybody that they have or talk about, have any questions?
I was just curious, when you're giving information on DMTs, and you're just giving all of them, would you narrow down a few and say, these are some that I would likely recommend for you? Or is it just kind of like, take a look at these? Just thinking of like running the risk of patients saying, well, I want to do this Tysabri, every 4 weeks, whatever. And you're like, actually, that's not really good for you.
Well, so again, when I first start the conversation with individuals about disease-modifying therapy, I usually talk about mechanisms of action, because that's, there's 23 drugs, and so I kind of talk about mechanism of actions. I kind of talk about the platform therapies are all kind of 30% effective, and you have to inject yourself. I do share with them many of the disease-modifying therapies, despite their efficacy and how they're given. Some of them, their monitoring requirements might be less than monitoring requirements for a drug that might be, quote, safer. And so that's where I start with is that. So I don't, but when she left my office, like I said, I gave her a paper that had all 23 drugs on there. And the outline was, how is it given, who's the drug company, the monitoring requirement, big side effects, and where they could get reliable information. And most of the time, that's the drug company's website is there. But sometimes I have the MS Society's or the MSAA's information there too. Good question.
You actually just answered a little bit of my question here. In our practice, our providers will have the conversation about DMTs with the patients in the room. But then if the patient's undecided, a lot of times they'll give them the manufacturer's website. I'd like you to take some time to research the options, see what you think. We'll have our nurse follow up with you in a couple weeks or in a week or 3 weeks. I'll get a message sent to me saying the time frame to follow up with the patient. At that time, I find a lot of patients are really deferring the decision. Well, give me a little bit more time to think about it. Or they'll ask a question or two, and then they want a little bit more time. What resources do you find are, I guess, best? Or do you have a toolkit of resources that you often refer patients to? A lot of the times I get
a fear of the medications because of the potential side effects. They read about cancers or hair loss or whatever. And that to them is more scary than the possibility of disease progression. So we have a few tools that we use to address those issues. But do you have recommendations for a toolkit that has all of these things spelled out for the different medications about here's the incidence of this side effect or the incidence of that potential? You know, what tools do you find are most beneficial for helping patients to make those determinations after or in between the clinic visits?
One of the things I said I gave this patient when she left my office, besides the 23 list of medications, is she got information about our MS Center. And so getting information about our MS Center is truly information that I have written. And so in that comes, there's some one-pager on urgency of treatment, and I have a couple quotes in there about urgency of treatment. And then in another one talking about monitoring, I have a quote in there from me that, you know, there is nothing that scares me more about MS than MS. There is no disease-modifying therapy that scares me more than MS. And so they get a couple quotes, and they're labeled from me, but they get some other information in there of reliable sites, the MS Society site, and I point out for them the newly diagnosed area and the MSAA, and the MS Foundation is in my area too, and they have good information. And so in that is not only information for them, I also have from the MS Society, I have the Navigator sheet in there if they want to use the Navigator. But they also then can use that for, I remind them a couple times after in subsequent appointments, all that good information I gave you about those associations, they all have money to help you. Just like the drug companies, they all have money to help you. So, yes. Yeah, I you know, in there when I have all the list of resources, you know, I say that what you hear is not reliable if it didn't come from these reliable websites. And if you want to know about a drug, the drug company is much more obligated to tell you about the risk of their drug than the benefit of their drug.
So as a person living with MS and an MS advocate, a lot of what you described here happens to a lot of us. We don't get the information as far as the MS in a good light. So the doctors potentially don't tell us right away, or like her, she, you know, maybe she had MS before and she didn't know it, or she walked out of the hospital and didn't know what she had. So I think it's really important for, because it is a shock to most of us that have MS, it's important for doctors to give us the information, but also go through the information with us. Because like her, you know, I was given all of these drugs that I could take, and I had absolutely no idea and was terrified by each and every one of them. And because each and every one of us is different, the medications are going to work differently. So those are some things that I think doctors can maybe do a better job at just saying, hey, you know, your MS is different, medications are going to be different, going through everything, because we have no idea. Some of us don't even know what MS is until we get diagnosed. So.
Well, my thing to patients is that you need to see somebody who does MS. You need to see an MS specialist or somebody who sees a lot of MS. The other thing is that, to your point, as you know, some providers that I've talked to way back when we used to have kits, I don't know if any of you remember kits, but when disease-modifying therapies first came out, they all came out with these kits. And we could potentially send a patient out with a grocery bag full of kits. And some providers think, well, if I gave them all the kits and they come back and I tell them what did they decide. That's not shared decision-making. Part of the biggest component of shared decision-making, you can't make a decision if you don't know what you're deciding about. So the onus is truly on the healthcare provider to educate the patient, because they can't make a decision without education. And if you're asking them to make a decision without education, that's unethical, in my mind. Well, you guys have been great. Thank you so much for hanging in. These are on the session. You can download these slides, so all the references are on the slides. And I look forward to that MS support tool becoming available very soon.